So good morning, students. Welcome into the 65th annual scientific meeting of Indian Orthopaedic Association, that is mini IOACON, a metaphysical conference conceived and planned during these pandemic times. We're going to have an excellent PG session with galaxy of speakers and a lot of cases, threadbare discussion, brainstorming sessions. But we got a delay in the proceedings because there is a thesis evaluation going on in SMS, and there are 70-80 students registered for this very program. So we will be starting it shortly by 10 or 10:30, and we will finish it by 6. So there is just 1 hour or so it will take. That is important announcement. Stay tuned with us. This is the pitch report so far. 10 o'clock, 10:30, we will have another inspection of pitch, and we will start the game. Thank you.
Hello. Good morning, everybody, and welcome on behalf of IOAPG Committee, Indian Orthopaedic Association, and IOAC 65th Annual Conference PG Organizing Committee. We are going to start the PG course here in Jaipur. I welcome our beloved Professor Rasimena, the organizing chairman and secretary, I've been the president in an Orthopaedic Association and present here, Professor Ajay Singh, Professor Ashish Kumar, Professor A.K. Pal, Dr. Pankaj Jain, and the PGTs here, present here. Now, Professor R.C. Meena will talk to you. Professor Meena, please. In the meantime, one more announcement is there. At the end of the course, what we have an OSCE examination. The questions will be based on the topic which will be discussed today by different faculty members. And there's a notebook in your chair, and you keep it with care, and we'll have short answer. About 10 to 15 questions will be there. It is for 30 minutes. And just to assess that how much you have will learn from this course. So please collect this notebook kept in your seat.
Thank you.
Professor.
So thank you very much, sir. MM sir, giving your valuable time in this difficult period and a challenging COVID dark period. Faculty, thank you very much, Ashish, learned faculty in front of the dais, and the students. PG teaching is a program of the IOACON, very essential because today's PG will be the faculty of tomorrow. That's why we prepare the PGs. Automatically. अच्छा दब तो नहीं गया मेरे हाथ से कुछ है शायद to prepare for PG practical है. So we have to explain the student, we have to prepare the student to face the PG practical examination and theory and discussion during their final examination. One most important thing is this of the PG teaching program is this, that when we having all kind of investigations and gadgets in our hand and a keyboard that is known as the Google, on that we can find the solution of every problem. But in spite of that, for the PGs, after 3-year training, we have a practical examination. And if you see what is the aim of that practical examination, why we keep 3 hours program for practical examination for the PGs? What is the purpose? Why we base the time of in my institution for the 30 students 3 days at least? So the aim of this wasting 3 time, consuming 3 hours, and after 3 years for a PG is PG practical examination. So for that, how you have to prepare, and you get the maximum score in your exam for your career, for your future practice. So friend, PG practical exam are nightmare for all the students. Before the examination, they are in a very shock condition and in a very anxious condition, And for that, they think what is to be done in a very terrific experience of in mind and in the mayors. And so, what to do in that scenario? Whether we have to read the Hanuman Chalisa or we have to fun on our training course, or remember the Lord Hanuman Shiva, or mark a petty excuse to examiner, sir, I couldn't get proper rest, and there was some problem in my family and my society and my institutes. That's why I am not fully ready to take this preparation. Or sometime beg your head of department for mercy. Please grant me, sir, I have worked for 3 years, but that is not justified. You have to prove your talent. For that, you have to follow some basic principles. What are these basic principles? First, you know your subject, for what you are going to appear in this practical examination, and what you are reading, and what training you have gained for last 3 years through which book, why which book, and you have to read the standard class book so that if you give the reference, everybody can accept it. Like this, and then identify the potential practical cases and prepare accordingly. Otherwise, if you read the so many things, but during the examination, all the things and so many things will not be asked. For that, you have to identify the potential things. There's say long case. Long case always and almost choose either from the hip or from the spine. There is a slogan and a very well-known fact that before any examination, so many news, day-to-day media, television or newspapers, that paper has been out, paper has been disclosed, exam should be cancelled. But here I disclose, I out your paper that only 2 cases will be asked from you during your PG examination. Now it depends on you that how do you solve. And nobody can challenge me that you have disclosed the paper, you have make out the paper, and you have opened the paper before the examination. Here I am open the paper before your practical examination. Only 2 cases will come to you, either hip or either spine. But now the thing is this, that how do you present these cases during your practical examination? Again, that I am solving you so that you became full proof for that practical examination. And the next is the short cases, either from the bone infection or from the swelling of the bone, whether it is benign or malignant, and non-union, delayed union, or malunion, and then some congenital problems, deformity, CTV or deformity. So out of these 7 cases, I am sure no examiner will ask you during the practical examination. But in spite of all these things, which are tell you before the examination, at the time of examination, I do not know what happened. You are not able to answer properly. Neither you try to understand how to present the case and examine the case. That is the aim of the practical examination, that how do you develop a rapport in between the examiner and yourself and the patient. And patient have a faith in you that you are real a doctor. You can satisfy your patient by doing the examination of the patient, by asking the multiple questions like that. And then after that, these potential 2 things, long case and short case, you have to focus on the study of the X-ray, surgical instruments, surgical implants, and pathological specimen. Out of these 12 things, no syllabus is for your practical examination, but I have taken the exam of the 350 students in my career since I became an examiner. And across the country, more than 350 students are my pass out. Either they are in various different capacity, but when I watch them, when I examine them, they all were in a really very threatened condition and in a very depressed condition. Many of them, of course, were up to the mark and in good condition. So, friend, what you have to do during the examination, I have seen many times the students, they do not bring their pen or marker for examination. These things leave a good impression or bad impression about you in the mind of brain of the teacher or examination. So bring a pen and marker along with you during the examination. Then bring a goniometer of good quality, not a short quality or short size 6 inch. You will again irritate your examiner with a short size goniometer. You have to bring a, because it is 3 years examination. सो डोंट बी सो कंजूस की आप 6 इंच का आप एक गोनियोमीटर ले जा रहे हैं, वो भी प्लास्टिक का जो हिल रहा है, कभी डुल रहा है, कभी फिक्स नहीं हो रहा है. सो इट इज योर मेमोरेबल थिंग. एंड देन ए मेजर टेप. Sometimes what I see that Mr. X demanding the measure tape from the Y and Y demanding from the C and C demanding from the A. So you should have your own measure tape during the examination, and then a hammer if the case of neurological associated there and come to you. Then a cotton wool see the sensory problem or loss and impairment of sensory system, and then tuning fork for the reflexes like that, and then stethoscope, of course. Should not forget to bring the stethoscope because the patient is sick of your examination. He might have underlying comorbidity that has to be examined and deal on with the stethoscope. So after carrying all and loaded with these things, and the 12 items which I told you, if you go through them, I am sure you will 100% success in your examination. Choice is yours whether you accept or you follow this principle and protocol or not. It is up to you. But apart from this, the another thing is this: go well dressed, not in t-shirt or short pant or half shirt and in slipper. So go with the well dressed, ironed place, washed, ironed, labeled apron, labeled with the thread that Dr. Alan Work, Dr. R.C. Meena, like that. Don't put a sticker on the paper R.C. Meena so that it became folded during the examination course and sometimes it fall down the on the floor. All these things leave a good impression in the mind of examination that a student is really a student and has taken proper training for his tenure. And then a formal dress, polished shoe, combed hair. But what you have to do after all these things? Be polite to your examiner during your examination. Never unnecessarily refute the examiner version, and be humble to your examiner. Accept whatever mistake you have done gracefully. Yes, sir. Sorry, it was up to my knowledge, but I accept I may be wrong. But then answer to the point to the examiner. Don't say irrelevantly. Sometimes say for example, examination of hip joint, it should be started in a sequential way. Don't say that initially you say that he's complaining of the pain, or next time you are saying, sir, he having shortening. Say he having the complaint of pain, why this complaint is originated, this pain was originated, and due to this pain and complaint, what deformity he has developed, and due to this deformity, what his normal physical life and attitude has been changed. That should go in a to the point manner, and then be gentle to the patient as well. Not rudely, otherwise patient will not cooperate you and will not give you the proper information and correct information about his illness and disease. And then examine the patient from right side of the couch. This is a very common question, frequently asked, from which side you have to examine. There is no valid justification from the examination from the right side, but usually it is widely accepted because the examiner can sit on the opposite side. Then take patient's permission before examination, legally as well as morally and ethically. And then an adequate exposure of the examining part. Why? A proper covering of the private part is, and keeping him privacy as well. And in the last, say thanks to you, to the examiner, and to the patient as well. These are the some photographs. How to do you behave? How you have to go into the dress, and how you have to perform the examination like this. That give a gentleman impression to the examiner. But what you have not to do during the examination, that do not come over or in a savvy dressed, and do not bluff or lie to the examiner, because as you know, they have gone through your stage already many years back. I have gone that stage in the year 1983 to 85. So if some student says, sir, this, I have passed that stage, and now I am 62 and have taken exam since 2004. And in the last, thank you, no, and do not think that you know the everythings. Sometimes the examiner asks you, and in your mind, I know everything, so I can reply to the examiner. But if examiner asks you that in short way, if he want to pull your leg, or if he want to make you unrest or make you in a tight position, he simply asks a question. Have you say for example examination of the hip joint? At the same time, he asks a question, why the underground, or why the thinking that you know everything. He will ask you, apart from the hip joint, correlate what else problem he having. Now you are not able to tell what problems he having. You will search so many problems. You cannot search so many problems at the same time. So in that scenario, think you know everything is not a justified thing. And never argue with the examiner. He is much intelligent, much experienced, and more knowledgeable than you. And in the last, do not know that I know, don't say that I know everything. So the take-home message is from my lecture and this opening ceremony is this: concentrate on your practical topic, whether it is hip or knee. Focus your own knowledge on that, and go in a proper dress, and then take necessary things along with you of the practical examination point of view, and be polite and relaxed, and do examination thoroughly, not in short course, but keep in the mind time slot allotted for the examination. As per university guideline, only 30 minutes are for the long case and 10 minutes for the short case. 40 minutes period is given to you. And if you extend this period, or in spite of that, suppose if you are not able to answer properly, that leave a bad impression on the examination. So you have to fix a target that I have to examine this case within the 30 minutes anyhow. And then do not lie and manipulate the things or argue with your examiner. And overconfidence is always and almost harmful. And in the last but not least, thanks to your teacher, your examiner, your students as well. So thank you and all the best for your future examination and endeavor and career. Thank you very much. So nice. Please.
Thank you, Professor Meena. And before we start the actual part of, I would request Professor Ajay Singh to come in the dais, and Professor Ashish Kumar, please. The next session will be on hip, but before that, I will give you a few tips. You have this program.
छोड़ वो छोड़ दी सर तो लगा हुआ है इसमें
We should start this session, and I would like to invite Professor M. Bray to start the ball rolling.
Good morning. In continuation with the Professor Mayner's talk, I will be very specific how to score maximum in the practical exam. And that is very, very important because in the exam hall, you know, these issues are clinical case presentation. While you case present, before that, may I ask you, is there any DOT candidate here? DOT candidate here? Is there any MA short candidate here? MA short? MA short, all of you mostly. DNB, how many DNB candidates? Is there anybody? Nowadays, you know, this DNB and the short case, long case in DNB are the same. There is no such differentiation between long case and short case. Only the cases, clinical case. And MS probably short case and long case is divided. Anyway, whatever may be the case is that working. No? In case presentation, you know, particularly you will have to be very particular. The issues will be there about the clinical case, clinical conditions. Suppose a de Quervain's disease or the dupuytren's contracture. I will come to that. Then issues is how you diagnose it, and then differential diagnosis, some demonstration of clinical test, then how to approach your treatment plan, and sometimes the prognosis. So I will come about that clinical conditions. Suppose you have been given a case of dupuytren's contracture or a Maitland's deformity. The examiner might ask you what it is or its pathological basis. That is one part about the clinical question before they start crushing you. And then the diagnosis. Then examiner will definitely ask you that how do you diagnose? So for diagnosis, you know, you will have to take points, strong points from each part. History, from inspection, palpation, movements, measurements, and others. And because you know, you will be asked for the provisional diagnosis. And the provisional diagnosis is based on the history and examination findings. And particularly the history, you know, that history contributes about 70 to 80 or sometimes more than clinical data from which you can diagnose the particular case and other findings. So about the history, you must be very particular. From history, you know, for example, a case of chronic osteomyelitis, the strong points, what we'll get? The chronic discharge from the wound or extrusion, history of extrusion of bone chips from the wound. That might be, but you should not miss these things if you get in that particular case. Sometimes inspection. No, inspection in certain cases, it is very, very important. For example, a case of CTB has been given. Your inspectory findings are very important for diagnosis. You may be asked what you find there in the lateral border, medial border, in the dorsum, in the sole, on the heel, in the back of the heel, what you get, all these things. Or a case of like this, hip case. You see, you can see the light from the opposite side, there is an exaggerated lumbar lordosis. These findings, inspectory findings, you must mention in your case. Palpation, you see that a case of exostosis or a chronic osteomyelitis, exostosis, the palpatory finding is very, very important, whether it's a pedunculate, sessile or not, or the hard bony swelling, where from it comes, or a case of chronic osteomyelitis, you see that sir, the local temperature might be raised, it might be tender, the surface maybe bone may be thickened, there might be some irregularity. So these viewpoint, palpatory point, you should note. And from movement, so in movement also, for example, a case, a hip case, it might be that all the movements are restricted. So for example, TB hip, the global restriction and painful might be, or certain movements of the hip joints are restricted, and that is specific for certain clinical conditions that you might note, and be very much particular in mentioning in that clinical cases which matches. Or measurement. Measurement, it is whether it is relevant to your clinical case. For example, a case of old posterior dislocation or anterior dislocation, you may get shortening with a typical deformity, or it is lengthening with that typical deformity, as you see here. You can guess the clinical condition, your length, your deformity, that will justify your diagnosis, or in the case like this, old anterior dislocations, there is lengthening of the limb. So length measurement sometimes very, very important, and that should be mentioned in your clinical diagnosis. So to make a provisional diagnosis, you collect all these points, strong points from history, inspection, palpation, movements, measurements, or others. Then you collect it, you think twice, thrice, 4 times, 5 times like that, and make few sentences, 3-4 lines that I have collected strong points from here, there, and all inspection. And then you repeat it, you recapitulate it, and finally you confess to the examiner that my diagnosis is here. This one is my clinical diagnosis because I got this clinical data with me from history and other examination finding. Then the examiner will be very happy. Otherwise, if you start like that, movement is restricted, that's why it is not that. See chronologically and serially from history to measurements and other findings, you must be very essential. About the differential diagnosis, your clinical, you have, suppose a case of chronic osteomyelitis, but clinical diagnosis should be, a differential diagnosis should be other clinical conditions which will be similar to that, like infective conditions, like a Capes disease. It has got a look like, almost like that, but there are certain differences. Then you will be asked to demonstrate certain tests. You know, this any test from right now, you should know the principle of that test, and common tests should be very perfect in the technique. And it comes only if you practice it very sincerely from right now. All tests, like I'm coming to that, and mere theoretical knowledge will not be enough. So you will have to practice that in a dummy patient or real patient. For example, this Thomas test, what actually it should be done and how you do it, you practice it with your theoretical knowledge, or a bilateral FFD, how to demonstrate it, or a telescopic test, how you do it, push, pull, where should be your hand. And this technique and your theoretical knowledge as well is required to justify. Examiner might ask you why you are pushing it, what is your function of your left hand, like that. So after doing these things, then you will be able, when the examiner might ask you how to approach, or it might be how will you manage the case, or what will you do now. Then you will definitely say that X-ray or investigation, X-ray, MRI, CT, or routine blood, or others. For example, you have been given an old ununited fractured neck femur. So it definitely will say that X-ray, MRI, and all you will do it. If, for example, the below 60 healthy farmer with 6 to 8 years old fractured neck femur without any comorbidity. If you say X-ray, examiner might ask you what is expected, what for, what information you will get. So either fracture displacement, neck absorption, comminution, or avian evidence exact, or head collapse, osteoporosis, degenerative changes in the joint, all, everything. That point should be noted, whether you get it or not, or you are expecting for which you are going for. Similarly, MRI. If you suggest MRI, it is not that randomly I have said MRI, CT, and all tests I'll do. If you go for that, what is your intention? What for you doing this test? So if you do for the evidence of avian in MRI or total or partial head collapse, evidence of fracture union process or degenerative changes in the joint. Similarly, from CT scan, if you prescribe, what information you'll actually get, that is important, and examiner might ask you. You may not get that, but, and routine tests are there. That is not only for anesthetic fitness, for correction of physiological and medical issues, and for safety of the patients and surgical team, and medical legal documentation as well. That's why. So at the final part, then you will have examiner, before you plan for the treatment, you should know what are the clinical problems. After seeing, now you at this stage, you have seen that patients with your clinical findings, and then you have also just seen that X-ray. So clinical data and radiological data, all these things are with you. So clinical radiological problem you will have to assess, and then you formulate the treatment plan. So in the similar case, a fracture neck femur, what is your problem now? Is it ununited only? Or is it painful? The hip is painful. Is it painful and deformed hip? Is it ununited with neck absorption? Is it ununited with avian changes? Is it ununited with way changes? So all these things to be formatted, you will have to assess. And then only you will be able to treatment, which treatment will formulate. For example, the ununited way with way changes. Then we will have to separate thing. Or if it is just ununited and no other changes, you will, a separate treatment will be there. Because you know, at the end, what is your aim? Now, aim is the painless, stable, mobile hip with or without osteosynthesis. Okay. So then you, in the similar case, treatment plan might be MPBG, muscle petrifical bone graft, with neck absorption and segmental necrosis in non-bearing area. Or you may formulate that fixation and fibular grafting in absence of collapse and neck absorption, osteotomy, modified piles or other valgus osteotomy, or a revision CHS sometimes, or THR in case of gross way changes, depending on the clinico-radiological problem. That you will have to settle before you plan for that treatment. That is important. So these are the few examples like that, neck femur, like this. And finally, the prognosis. There are certain cases where prognosis is important. For example, a neck femur, you have done this CHS, and ultimately, what will happen? The patient, what will see? That whether it is it the everything done, and what is the fate? There are certain cases that fracture may not unite. Certain cases there might be some failure. So you'll have to dictate that, and you'll have to communicate with the patient's relation that certain percent will definitely be successful, but certain percent may not. In that case, you will have to revision, second procedure, or something else. So message is that at the end, that to convince the examiner that you are confident enough to diagnose an orthopedic problem with available clinical data. After taking history and clinical examination, you have sufficient clinical data to diagnose correctly and manage the patient best with your practical knowledge, with all investigation and the best treatment which will justify with your clinical and radiological data. Thank you very much for this.
Thank you, Dr. Ray. It's an elaborative way how you should proceed in your examination and present your case. So as much you practice, that much you learn. If you want to ask some question, Dr. Ray is here. It's a bilateral communication. That's the best thing you can have in this type of class. Otherwise, there's hardly any sense that we are just
Yeah.
speaking and
We are running short
going
of time.
away
I
from
think
here. But
whole day
anyway,
will
one
be
or two.
here.
Okay.
Anytime you can ask any question to the faculty is all here. Dr. Swarnendu Samant is already here. He has come. And to Dr. Gigi Kaur and any questions to you. The whole day will be here. Now,
Dr. Pal,
next
Dr.
part
A.K.
will
Pal, he is presenting Parthi's hip case. One of the very common thing you will get in your examination. Dr. Ajay Singh is here. He is again a pediatric orthopedic surgeon. He is dealing with so many ways of treating Parthis. So we are fortunate to have him with
Okay.
us. Thank you.
Okay. So good morning, everybody. My beloved students, respected chairpersons, Professor M. Roy, Dr. D.G. Kaur, Dr. Singh, and Dr. Shanandu Shamantan, all the dignitaries. So today my topic of discussion is the Parthis case. So before doing that, so we have to start a case which is a very unbiased manner. Okay. So this is a 8 years old boy from Behrampur, Murshidabad, presented with a cheap complaints of painless limping for the past 1.5 years. Okay. So this is the history of present illness. Just I am going to present the case as I am being a student. I am going to present the case in front of the examiner. So mind it. So is there any questions? Please note it, and we'll discuss why I'm doing this. And this is very, very important for you because this is also a guide for examination of the hip also. Okay. So patient was relatively well 1.5 years back ago. The patient received a trivial trauma to the right hip, which was managed by analgesics. The patient didn't need any immobilization or any surgical management before starting these normal activities. 15 days following the exact incident, the patient developed the limping. The limping is painless, non-progressive, and is not associated with any loss of activities of the daily living. The patient can squat and sit cross-legged without any difficulty. And there is no associated history of any fever, evening rise of temperature, or any weight loss. There is no history of other joint involvement. There is no loss of appetite, loss of body weight, no disturbance of the bladder, bowel, and sleep. So that is the basis of this history of present illness. So my opinion, there is a cheap complaint, is a painless limping. The body of the present illness, history of present illness, should be subdivided into 3 components. In one component is the elaboration of the cheap complaints. Next component is the important positive history in favor of your diagnosis, and important negative history to rule out the other diagnosis, which is will come in your mind. As you can see here, this is the first point, second, third, fourth, and fifth. These are the elaboration of the chip complaints. The 6th point is a point which will negate the other possible diagnosis, like infected disease, like inflammatory disease. And lastly, the most important is there is a cardinal symptoms. This is the most important, and this is it should be mentioned in all cases, because if these cardinal symptoms are positive, that indicates a grave sinister significance. So that would indicate there is a very bad prognostic disease, like malignant disease, or a infective disease which is progressive in nature, like chronic tubercular infection, or a pathogenic infection is spreading in nature. So this is the last one is the cardinal symptoms. So history of present illness is divided into 3 components. Now, history of past illness. What do you mean the past illness? See, there is an incident which is related with this complaint. So this is, it will not come in the past illness. But the past illness is the illness after which there is some symptomless period. This is most important. As you can see here, you have to mention in this case, there is no significant past history of severe trauma requiring prolonged bed rest or hospitalization, or severe, like that is, I will exclude the traumatic case, or severe pain over groin with high fever requiring treatment. So we exclude some septic arthritis, like infective disease, or chronic osteomyelitis or acute osteomyelitis in previous days, or any history of discharge from the upper thigh. So that is, they exclude the chronic infective focus from the proximal femur. So this is the important past illness. Now, personal history will go by your alphabetic manner: A, B, C, D, E, F. A for there is no history of allergy. B for there is no abnormal birth history or abnormal bleeding episodes. C for no history of contact with any known patient or tuberculosis or any other infectious diseases. And D4, they need no history of prolonged consumption of any drug history. And the developmental milestone, especially it is particularly important in this case, as the developmental milestone is important, as I'm not going to detail. If you ask, you can, the specific milestone is sitting, standing unsupported, standing with support, and there is a that walking with support, walking without support, and running, and bladder control. This is a basic developmental milestone. Next is the E is the economic status and the environmental history. This is most important because that will carry some significance regarding the diseases. And there is no history relevant, no family history. There's some diseases run in the family, so it is most important. And there is the immunization history. And if it's adult female, then we have to take the menstrual history. Okay. Now analysis of the history. So you see the patient has a painless unilateral limb in an 8 years boy without significant trauma, fever, or pain in other joints. Is non-progressive. So if you ask, I can tell why it is non-progressive. And insignificant past and personal history. So basically it indicates a mechanical defect. How will you rule out the infected cases? Can anybody tell? How will you rule out the infective cases? Can anybody please join? Join. It will take time, but it will be very much. Can I? Can it be interactive, or will just? But if we make interactive, then it will be like. Okay. So how will you exclude the infected causes? Very short. Just. Yes. Yes. So we have excluded the so basically pain. So from the pain, how will you ascertain whether the pain is from mechanical cause, it may be from the inflammatory cause, or it may be from the infective or neoplastic cause, isn't it? From pain, so what are the from history? How do you differentiate this mechanical pain, infective pain, and the inflammatory pain? Can you please certain? Very good. It's the aggravating factor and relieving factor. So mechanical pain, it will be aggravated by activity and relieved by the rest. Inflammatory pain is just opposite. It is the pain is aggravated by rest, relieved by activity. Whereas in the infective or neoplastic pain, as the cause is always present, so there will be pain is aggravated by activity, but there is no relieving factor unless there is taken some medication or some anything specially. Otherwise, there no. So this is the mechanical defects. So this is the points in favor of diagnosis from the history part. So it's a mechanical defect of the proximal femur, because this is confined to there's a limping, patient is complaining of pain, and so this is most probably it is a coxa vera deformity, which is secondary to this is it's 8 years age. It's commonly it's avascular necrosis of the epiphysis of the proximal femur, is a perthes. It's a developmental coxa vera. It may be dysplasia group, or it may be congenital femoral shortening of the deficiency that may lead to short limb gait and limping, painless limping. And the malunited pathological fractures. The malunited means that is the inflammation is subside. That is why it is painless limb. Okay. And any benign neoplasia like aneurysmal bone cyst, simple bone cyst, fibrous dysplasia can lead to this type of malunited neck femur fracture. Or there is unstable hip as a sequel of septic arthritis. That is why. How will you exclude? Will come later on. How will you exclude it? We'll keep it later part. Metabolic bone disease like cretinism or the ricket. Now, general examination, there is nothing significant. I'm not going into detail, but these are the enumeration which is should be made in our examination. Next is the locomotor system examination. Now, so see, what is the gait? Can anybody please explain? Very good. Why are you telling us a tendon gait? No, notching on bone. Pelvis is sagging down in which side? Same side. That is the answer. So there is a pelvis is there is swaying of the center of the gravity, or that is the same side. This is a separate case. This is not of case, but this is the case actually. See, what is the gait? This is the clinical photograph of this case. What is this gait? See, no, just Same, it is a tendon market. That is, I have kept it. It is same, it is a tendon market. See, already the body is swaying on the right side. Patient is complaining of limping on the spineless limb on the right side. See the posture. It is a body is swaying on the right side. So how do we ascertain? How do we ascertain whether it is a short limb gait or it is a tendon market? This is almost looking similar, isn't it? That is the questions. The short limb gait, there is a drooping of the pelvis and it is going vertically up and down. It is not swaying of the body in the coronal plane. This is most important. So that is why please check it. See, the body is swaying in the coronal plane. This is most important. Shoulder is drooping down and the body is swaying in the coronal plane. That is most important. See, this is another case. This is a pure short limb gait. See, this is shoulder is drooping up and down. There is no swaying of the body side by in the coronal plane. So this is a typical short limb gait. This is not a case, but for the comparison, I've kept it. So examination of the front, the head. So what are the points to be examined from the front? Head should be central. Right shoulder appears to be at a lower level, as you can see here. And no obvious wasting is seen. Attitude of the limbs are comparable bilaterally. No scars, sinus, lumps, venous prominence is seen. And from the back, head is central. Right shoulder at a lower level. No scoliosis is seen. And there is no obvious wasting is seen. From side, no abnormal lordosis or kyphosis. Now, these are the points it is written by some students. See, this is some OSCE will be there. So spot the relevant one, which is written in this examination in supine position. The points to be noted. So there are some students written these points. ASI is at the same level. Patellar position is at the higher level on the right. Position of the right medial malleus is above the left. And the right heel appears to be at a higher level than the left. Spot the relevant one among are the all relevant, or some one or 2 points may be relevant and sufficient. And there are one important inspectory finding is missing. Can anybody spot that inspectory finding? Pardon? They have written ASI is at the same level. Now, first spot the relevant one. All the 4 points are relevant? Yes or no? No. So which one? Is 1 or 2 point is relevant? Spot it out. Pardon? Patella. Anybody else? Malleolus. Anybody else? ASIS. So see, inspection. How do you ascertain where is the ASIS? Is it the confirmatory? Is the ASIS is confirmly spotted in inspection? So you have got your answer. Again, so is it confirmatory to absolutely mention the patellar position in inspection? Yes, no. Is it confirmatory to diagnose exactly the position of the medial malleolus where it is? Which part of the medial malleolus is important to see the position? Medial malleolus is a large area. Tip of the medial malleolus. So is it possible to spot the tip of the medial malleolus in inspection? See, these are the mistakes is done in your examination. So what is the relevant one? What is the relevant one which is not uttered till now by anybody? Yes. So right heel appears to be at a higher level on the left, which is seen from the top or from the side. That indicates there are limb length discrepancy. There is a possibility of limb length discrepancy on the which side? This is right limping. So it is a right side. Okay. Is it clear? Now, which one is there is another important point is missing. Can anybody spot that? No. Yes. Wasting of the right quadriceps, and somebody tell there is a wasting of the right calf also. Okay. It is obvious on the right side. So see, only the relevant point we have to write. Okay. Now, palpation of the right hip. First, we have to palpate the temperature. We have to mention temperature of the Scarpa's triangle, whether it's normal or not abnormal. Then ASIs, we have to identify the ASIs. Now, this is the time where we have to identify the ASIs. There are some methods we can ask how to identify the ASIs, level of the ASIs. And another important question is sometimes, most of the times, when I was in a student, there is some controversy whether the ASIs is at a higher level or lower level or same level. It is always there some. I was in a very in dilemma. That is why I put the questions. So how will you confirm that? You have palpated. You have palpated the SIS, but you are in a dilemma. SIS may be at a higher level or lower level. How do you make it confirm? Can anybody tell? Squaring the pelvis requires first point is SIS should be at a higher level or lower level. Then the squaring will come. Question of squaring will come. So there's a dilemma is in the first point. Whether ISIS may be at a higher level or lower level or same level. So how will you ascertain it? Limb length is already there is a limb length discrepancy, but in spite of that, there is a dilemma of size maybe higher or lower. Is the dilemma hoga ki nahi? Yes or no? Yes. So how will you sort out this dilemma? Can anybody tell, please? Try to it. See, SIS it is a higher level. What is the deformity? Adduction deformity. If it is a lower level, which is the deformity? So test that movement. If it is adduction deformity, which movement will be lost? Abduction movement will be lost. If it is adduction deformity, which movement will be lost? Abduction deformity. So check that movement, and you will the दूध के दूध पानी का पानी हो जाएगा. होगा कि नहीं? See, this is simple answer, isn't it? There is one. Second, if the patient is severely painful, patient will not be able to move. So if you cannot check the movement of the hip joint, so in that case, how will you check whether the SI is at same level or not? Unless you move the hip joint, you cannot check whether it is adduction is present or not. If both the adduction is present, SI is same level. If the abduction is lost, it is adduction deformity. If the adduction is lost, it is abduction deformity. But you are not able to move the joint because of severe pain, or it may be ankylosed, or it may be fixed pelvic obliquity. See, these are the situations where they cannot move the hip joint. So how do you ascertain whether the SI is at a same level or a different level? This question can be asked in different manner. So in different manner is, if the squaring of the pelvis cannot be done, then, and the SI is at a different level, how will you ascertain the abduction deformity? Now you will answer this. Yes. Yes. See, the question pattern may be different. Answer is the same. This is about the examination. Okay. So drawing the Kothari's angle will come. What is that? The Kothari's angle will come later on. So next is the anterior hip point is non-tender. So the greater trochanteric is non-tender. So there are what are the points to be examined for the GT. Greater trochanteric is non-tender, non-thickened, broadened, in the higher level than the right, on the right side than the left. Now next question: how do you know it is at a higher level? Can anybody answer this? Right side GT is at higher level. How do you know that at this level? See, there are two questions, two answers has come. One is digital Brand's triangle, another is the Brand's triangle. Any other answer? Third answer? Any other answer? See, we are very right. Digital, these are going on in the examination, but both are incorrect. I'm telling you, because being an examiner, it is being, so there is no digital Brand's triangle is written in any book. It is written that there is a digital palpation of 3 bony points around the hip joint. There is no entity of digital Brand's triangle. There is a digital palpation of the greater trochanter, or digital palpation of the 3 points of the Brand's triangle. That is different. You are right in this manner, but your questions answering it should be a little bit different. Okay, so that is the answer. Okay, now this is the bitrochanteric compression test is negative. Now the question is, how to differentiate the trochanteric tenderness and the bitrochanteric tenderness? I'm not going into detail. If you ask the answer, I will then I'll discuss. Now, femoral artery pulsation is palpable equally on both sides, and ease of palpation is same as on the opposite side. So, I mean, sometimes students wrote that vascular sign of Narath, it is positive or negative. But is there any question is there any entity of vascular sign of Narath negative is present in any book? No. in any hip case, there is no possibility of absence of femoral pulsation. Isn't it? Is it possibility? There are different medical conditions are there. There is absence of femoral pulsation, or there is some grave situation where the femoral pulsation may be absent in a severe traumatic condition. But these are not the case for examination. Okay. So there is a different. So this vascular sign of Narad may be normal or positive. Will come later. Now, external iliac and the cloacaed lymph nodes are not palpable. Now the movements. How do you write the movements? So these are the way to write the movements. See the right hip, which is the abnormal side or affected side, and the left is the normal side. So we have to start this fixed deformity, active passive, active passive. Okay. So in this case, as it is a not neurological disease, so active passive are same. But if it is a neurological disease, there is some active movement will be there, passive movement may be nil. So in that case, there's some complexity will come. Otherwise, it is very easy. Now for X, you have to write it down whether fixed deformity and what is the range of motion, whether the range of motion is associated with pain or not. And see, these are the abnormality in this case. There's a flexion, as all our movements are almost equal except the abduction, which is restricted, and the internal rotation in extension is 0 to 20 degree, whereas in internal rotation in flexion of the hip is 0 to 10 degree. Was it its significance? Was it? Yes, yes, it is very good. Series, sectorial sign. Not going. These are the videos. I'm just skipping the videos. I'm just skipping the videos, which is basically the method of examination of the internal rotation. Okay. See, just a minute. So this is the these are the abduction. This is the internal rotation. So what is the importance of this testing this rotation in prone position? Can you tell? There are examination of rotation can be done in supine position, in prone position. What is the importance of examination of testing of the rotation in prone position? Yes, measurement of the anteversion, that is a special one. But apart from that, for generally, comparison of both the side can be made simultaneously. This is most important. But it is very difficult if you examine in a supine position. It is very easy to compare on the both sides simultaneously. And patient will be very much comfortable. Okay? That is the answer. Now, sectorial sign, I'm not going to detail. Extension, I'm not going to detail. Now, where will you put the goniometers? Especially, so among these three figures, this is the measurement of flexion deformity, where the center of the goniometer should be placed, say here. That is the center of this anterior hip point, which is almost equivalent to the center of the hip. Is for the flexion, at the center of the goniometer should be placed on the tip of the greater trochanter. And this one, and it is a rotation. Is it? Okay. Okay. Okay, we'll just run it out. Okay, okay. So measurement, so there is a 1 centimeter shortening and there is a true shortening. And the special test, Tenderberg test is positive. See the Tenderberg test, I'm not going to detail. The summary, it is an 8 years old child presenting with a non-progressive painless limb developed after receiving a trivial trauma 1.5 years back. There's no history of fever, evening rise of temperature. These are the summaries most important in all cases. Evening rise of temperature, multiple joint pain. On examination, he appears to walk with Trendelenburg gait. He has restriction in abduction and internal rotation. The internal rotation gets further reduced on flexion of the hip. He has 1 centimeter true supratrochanteric femoral shortening and a positive Trendelenburg test. So diagnosis, my provisional diagnosis, it is a case of leg curl Perthes disease of the right hip in an 8 years old male child. Now, what are the points in favor? These are the points in favor. This is a boy of 8 years, is unilateral hip disease, is a painless limb after trivial trauma. Patient is complaint of Trendelenburg gait. This is a mechanical pattern of movement restriction, that is especially the abduction internal rotation is restricted, and especially the sectoral sign is positive. There is a mild limb discrepancy, almost 1 centimeter, and Trendelenburg test is positive. Important negative points you have to mention in this case, like no history of significant trauma, fever, and other joint pain. The anterior hip point is non-tender, which excludes the infective and inflammatory diseases. Telescopic test negative, which excludes the unstable hip, and no significant lymphadenopathy. Now, how to rule out the other diseases? These are next questions. Next, we have to answer. So there are differential diagnosis, developmental Coxa vara. Why not is a developmental Coxa vara? Because it is a developmental Coxa vara is commonly it is a bilateral, maybe unilateral, but most commonly it is a bilateral, and that will present with a waddling gait. It will be a progressive disease. There is an increased lordosis will be associated with this. Okay, and dysplasia group, that is same of the developmental Coxa vara, and associated with some generalized affection. The congenital short femoral deficiency, because it is not a congenital disease, so it will rule out the congenital short femoral deficiency. Malunited pathological fracture is if there is some swelling or any problem like ankylosing bone cyst or bone cyst, patient will complain of previous patient has some deep boring pain or any difficulty for long period. There is sudden onset, and with sudden onset of pain with a trivial trauma. The unstable hip is ruled out. There is no history, no significant past history suggestive of infection. Telescopic test is negative. Metabolic bone disease should be bilateral generalized problem. Infective inflammatories are always ruled out. So how to manage the patient? This is most important. So there are always, once we ask to manage the patient, there are three questions are hidden inside it. One is the confirmation of the diagnosis, which should be done by the AP and the lateral radiograph. Counseling should be done regarding the diagnosis, prognostication, and the treatment options. And lastly, the treatment option, treatment option will you adopt in this case, like the conservative or operative. Now, some special investigations is required. Which special investigation will be required in this case, particular in this case? There is anteroposterior radiograph in full abduction and internal rotation, which ascertain the position of containment is required for this. And as we detect the hinge abduction. We'll discuss, because there's a shortage of time, I'm not going to tell. Orthography may be required. It is not mandatory, but it may be required to ascertain the position of the containment. Now the radiograph, how to read the radiograph. So what are the radiograph features is required is asked in the examination. Like you have to staging, Catterall staging, Herring staging, and Elizabethtown classification. Header risk sign. See, this is the how to read the radiograph. This is the standard anteroposterior and lateral Lowenstein lateral radiograph showing. So what is that? See, will come from the acetabulum to downwards or from downwards to up. If you come from the femur, see the proximal femoral epiphysis. It is sclerosed. It is reduced height. Reduced height is but there is no extrusion as we draw the Perkins line. And if any part of the physis is outside the Perkins line, it is lateral extrusion. So there is no lateral extrusion. But see, the horizontal growth plate is relatively horizontal, and there's a metaphyseal cyst. These are the all headed sign. The bad prognostic sign, there's a whole head involvement. See the AP and lateral view. For commenting the whole head involvement, we have to see both the AP and the lateral view. Unless if it is only the AP view, don't comment on it. Always you have to see the lateral view. AP and lateral view, there's whole head involvement is one. There is a whole sclerosed. There's whole head is sclerosed. This is one. The second. And there is a metaphyseal cyst. See how large metaphyseal cyst. These are the all bad prognostic indicator, because that will indicate that this epiphysis it should extrude in due course of time, and that has to be prevented by your treatment. Plan of treatment is basically the containment. So the radiological stages, I'm not going to detail. If you ask, I can. This is basically the Elizabethtown classification is modified by Benjamin Joseph et al. So it's the first one, A1A, basically 1B, basically four types actually. There is a healing. There is one is the necrosis, B is the two is the revascularization, and 3 is the healing or the repair phase. 4th is the healed stage. So if it is how to know the necrosis phase, basically it is sclerosed. So whole is sclerosed, whole part is sclerosed, but it is not flattened. So if it is only sclerosis, it is 1A. If sclerosis plus flattening, it is a 1B. Now this revascularization starts. How to know the revascularization starts? This fissuring will come from the metaphyseal cyst. The blood vessels will come, and that will lead to, that means single fissure, that means multiple fissure, and depending on that, it may be single, there's a 2 fragment or multiple fragment.
Can we, can you summarize the feature, because we are already...
Okay. So so management is basically, it is a options. There are several options are there. We have to give a wet relief. It may be containment, it may be conservative or operative, or the GT fascial arrest. So factors to be containment, there are different types of containment. It may be conservative like brace or cast, operative may be femoral osteotomy or the pelvic osteotomy. So these are the outlines. Just I shall stop here. And there are several factors to be considered, like the age, clinical age should be, containment should be started at, if it is below 7 years, prognosis is good. 7 to 12 years, up to 12 years, containment can be done. After 12 years, containment cannot be done. It is useless. And there are several factors like pain and stiffness. If it is there, we have to correct it before its containment should be done. And the radiological point is we have to see the extent of the involvement, stage. It is the result of containment is good before stage 2B. and there's a lateral extrusion, there's a very, very bad prognostic indicator. Okay. So I think we will discuss later on. Okay. Thank you.
So, any question from the students? Any query?
So many.
Because it is a very important long case, and any hip examination is a very important long case. And as the speaker already highlighted, you should start with the analysis of the history and how you will, what is the relevant point, and you start making your provisional diagnosis from on the basis of history, whether it's a painless limb, then what are the causes of painless. So please, I request all the speakers and as well as all the students who are present here, we should do like a conversation between the two parties, so that the you may put forward the question and the student can answer the question. Thank you very much, sir.
We'll discuss. In any questions, please write it down. We'll discuss later on.
Dr. Pankaj Jain is here to present his case about the chronic osteomyelitis.
Thanks,
No,
sir.
it's ununited fracture neck femur.
My job already has been done more than 50%. The examination part and the x-rays have already been discussed. So I'll be very short and to the point. The topic given, the case given to me is ununited fracture neck femur. It's a case presentation. I'm Dr. Pankaj Jain, Senior Professor, Orthopedics, SMS Medical College. So what a postgraduate should know in this case, he should be able to examine the hip, should be able to give a proper detailed history, should be able to describe the examination points favoring a ununited fracture neck femur in the history. He should be able to give a differential diagnosis if is there any, and should be able to tell the management principles, investigations and treatment for the disease, for the ununited fracture. For the viva, for the discussion purpose, he should be well aware with the anatomy of the hip joint, should know about the vascularity of the adult hip, should know about the biomechanics of the adult hip. He should be able to tell about the role of various investigations like CT scan, MRI, when to go for angiography, and the bone scan. He should be able to describe the common procedures and principles used, especially for salvage of the adult hip. And lastly, should be able to tell the role of various arthroplastic techniques and recent advances. Your total ununited fracture will involve all these things regarding history and viva. So few definitions are important. US FDA definition of non-union fracture neck femur is minimum 9 months of post-injury and with no progressive signs of union for 3 months. Any displaced fracture neck femur, if it's not been under treatment, should be considered ununited or non-union from the day one. Neglected fracture is defined the fracture which is presenting to you 3 weeks after the injury. In the examination of hip, these points should be there in your examination, that patient is not able to walk or he walks with an antalgic or a Trenberg gait, already has been shown there. Shortening in a fracture neck femur case is usually less than an inch. External rotation of the lower limb is seen, and it's not very grossly external rotated. Upward displacement of the trochanter is seen, and most of the time fracture neck femur doesn't present with any deformity. There will be tenderness over the mid-inguinal point, but it can be absent in old cases. Active SLR, that is straight leg raising, should be negative in a fracture neck femur, but sometimes patient can do a slight elevation of the lower limb because of the fibrous union or fibrous contractures. Telescopy test is positive in an ununited fracture, and PGs should be able to demonstrate this test. Trenberg gait or test should always be demonstrated, and any examiner will ask you this question. The most common differential diagnosis is an intracapsular fracture neck femur, and you have to differentiate it from the intertrochanteric fracture. So intracapsular fracture, most common is you will have, if you have an ununited proximal femur fracture, it should be, as a saying, it should be ununited fracture neck femur. because non-union is common in neck femur and malunion is very common or the most common thing in intertrochanteric fractures. There will be tenderness over the mid-inguinal point in case of an intracapsular fracture, and in case of intertrochanteric, there will be tenderness at the trochanteric region. Trochanter should be smooth and there should be no broadening or irregularity in case of an intracapsular fracture neck femur. And there should be irregularity over the trochanter with broadening and thickening in case of intertrochanteric fractures. Regarding deformity, shortening, age, and extent of trauma, all these things are more in case of intertrochanteric fracture. So if a patient is presenting with a history of road traffic accident, he'll be having a intertrochanteric fracture. But if he is presenting with a trivial trauma, fall in bathroom, possibly he will have a fracture neck femur. Chances of having a fracture neck femur is more common. IOA, there was a publication in IOA 2005, IOA white paper. Dr. H.S. Sandhu presented the classification for neglected fracture neck femur, and he divided this in 3 types. Stage 1 says fracture edges are still irregular. The size of proximal fragment is 2.5 centimeters or more. The gap between the fracture fragment is 1 centimeter or less, and head of the femur is viable, and there is no signs of AVN on X-ray or MRI. Means it's an early stage patient presenting to you. Stage 2, it's in between. Fracture surfaces have become smooth and sclerosed. The size of the proximal fragment is 2.5 centimeters or more. The gap between the fragments is between 1 to 2.5 centimeters. Still, the head of femur is viable. And the stage 3, the fracture surfaces are smoothened out, totally avascular edges. The size of the proximal fragment, because of the rubbing, or it is less than 2.5 centimeters. The gap is more than 2.5 centimeters between the fragments, and femur head will be showing signs of avascular necrosis. This classification helps to decide us for the treatment principles. Regarding the anatomy, the basic should be the angle of inclination of femur. It approximates 125 degrees, ranges from 110 to 144. The greater trochanter, if you put a line tangential to the greater trochanter, it will be at the level of the center of the femoral head. And this is very commonly used in arthroplasty. So any increase in the angle is coxa valga, and any decrease in the angle is coxa vera. Regarding the vascularity, Kroc described 3 major group of vessels which are supplying the proximal femoral head. Extracapsular arterial ring is formed by the medial circumflex femoral artery and lateral circumflex femoral artery. These are most of the time branches from the profunda femoris. These branches make a circle, they go inside the capsule, make the retinacular vessels. These are divided into 4 types: anterior, posterior, medial, and lateral. The lateral vessels are the most important because they supply the weight-bearing zone of the femoral head. And the third one is the ligamentum teres artery, which supplies less than 20% of the vascularity of the head. And in alone, ligamentum teres will not maintain the vascularity of the head. So another question is commonly asked, why non-union is common after fracture neck femur? The absence of cambium layer of periosteum of femoral neck. One is reason. Cambium layer is the regenerative layer of the periosteum. Other is the fibrous layer. Fibrous layer is there, but because regeneration is not there, so union is not that callus formation is not good. And there is a continuous synovial fluid bathing of the fracture site. And because of the typical vascularity of the femoral neck, the non-union is more common. Other factors contributing to the non-union of femoral neck is surgeon dependent, where you have not achieved a good reduction or done a poor fixation. But vascular insufficiency and posterior comminution are the fracture characteristics which are responsible for non-union. Next question is asked, once you have finished your history examination, you will be asked, how will you manage this case now? So you have to say, I'll manage this case by, I'll first investigate to confirm my diagnosis. So what are the investigation you will order? For any hip case, I feel you should always go for X-ray of the pelvis, including both hips in internal rotation and both hips in as much as identical position. This will give you a mirror image of the injured side to compare with the normal side. CT scan is not useful in acute conditions unless until you are looking for posterior comminution. It's the best investigation to assess the fracture union once you have done the fixation. MRI is mainly used to assess the viability of the femoral head. And most of the time, you have to avoid the medical legal problems later, you want to get the MRI done. Bone scan, it is good to differentiate between avascular necrosis and non-union, but not in these cases, not in the ununited fracture. Presenting to you. The aim of treatment, in any hip case, it will be to achieve a painless, mobile and stable hip. So the treatment plan will be based on the age of the patient, physical status of the patient, the duration of non-union, viability and congruency of the femoral head, amount of resorption of femoral neck, you need to reconstruct or not, the neck or not, and the limb length inequality. Broadly, any hip will require two procedures: head salvage, which you will prefer, and everyone will prefer in younger age group, and head sacrificing in old age. Any examiner will ask you all these questions: how will you salvage the hip? So head salvage should be done in cases where you have a viable hip, concentric femoral head reduction with adequate neck to get the good biomechanics. Aim is to restore as normal as hip as possible.
Sir,
You
can you summarize, sir?
Sir, only 2 slides. You can do it with a fixation alone in the early types. You can go for osteotomy, valgus osteotomy with fixation. You can go for muscle pedicle bone grafting techniques. You can go for a cortical or cancerous bone grafting like fibula. And you can combine all these procedures: osteotomy, bone grafting, fixation. That is 3-in-1 procedure, or some people say is triple attack. Excision arthroplasty is most of the time out. Hemiarthroplasty or THR are the basis of decision. We'll prefer total hip replacement as a choice in cooperative, independent individual with a normal lifespan. Choices are cemented versus uncemented versus hybrid. Bearing surfaces will also be important in decision making. Hemiarthroplasty we prefer in less demand patients and who are leading a sedentary lifestyle. We have used AM processes, cervical processes, or a bipolar processes, or a modular process with or without cement in these cases. So the last slide is, irrespective of vascularity of head, if good reduction is achieved and neck shaft ankle is maintained, you will try to fix within 3 weeks with CC screws or DHS only. If in 3 weeks to 3 months, you want to augment fixation with bone grafting and muscle pedicle bone graft. After 3 months, with shortening and varus of the head, you can plan for osteotomy. Only cases with incongruency or segmental collapse, replacement arthroplasty or arthrodesis is the option. Thank you.
Thank you very much, sir. Any question from the student? Yes, please. Sorry, question? Repeat the question.
Synovial bathing means synovial fluid is covering the fracture site. It is not allowing the hematoma to accumulate there. So once you don't have a hematoma coming up, you don't have callus formation or a union.
As well as one more reason is there that the synovial fluid has some interleukins which inhibit the callus formation. So synovial fluid is one of the non-union factor. Any other question, please? So there are 2 lectures are already there on the hip examination. Can any PG student tell me what are the prerequisites for the apparent measurement and what are the prerequisites for the true measurement? Because you have to examine and you have to, the examiner will ask you what are the prerequisites of apparent measurement and true measurement. Any student? Because you are not asking, so I am asking. Either you ask or I will ask. Yes, please. Yes. Okay, what he's saying that for the apparent, both limbs should be parallel to each other. You have to add one more point, parallel to each other and parallel to the body axis of the body. In line. These are the 2 prerequisites for the apparent. And he said correctly that the mirror image with square pelvis are the prerequisite for the true measurement. One more question I want to ask. What are the classical deformity of fracture neck femur? In acute neck femur, what are the classical deformity? Flexion and adduction. But in non-union, whether you will get the classical deformity or not? No. Why no? Because patient is walking, the absorption of neck may have occurred. So that's why you are not getting the classical deformity. The case. Yes, yes.
Anybody can volunteer and can show us the exact demonstration of telescope. Anybody?
Any volunteer student? Come on. Either you nominate yourself, otherwise we will nominate anybody.
Dr. Jan, you select your student, somebody. Okay, he's there.
She is there. Okay.
Telescopic test.
Dr. Jan, please help him, help her. Thomas test is most important. Dr. Sahab, for what we do the Thomas test? You are going to do Thomas test. For which thing? What you want to see by this Thomas test?
So I want to assess if there is any flexion deformity in the
Any
hip.
flexion deformity?
Yes, sir.
Fixed
Fixed
flexion
flexion
deformity.
deformity in the
Yeah?
hip. So
When the patient lies supine,
yes, sir. If the patient
what
should
do
be
you
lying
see? What do you
supine-
see?
I don't. The patient should be lying supine on a hard couch, where we should be able to insinuate our fingers under the lumbar spine.
No, that is
First-
palpation.
First inspection. What do you inspect?
Exaggerated lumbar lordosis.
How you will?
How you
will-
inspect?
The gap between the
Yes.
spine
If
and
you
the
are
couch.
able to see through the spine very
Yes, sir.
clearly.
If you're able to see through the opposite side, then we'll
For that you need his hands to be removed.
Hands has to be removed. The cloth should be in the part should be well exposed.
Yes.
Only then you can start. Don't do start.
sure. आपके हाथ को जरा और मैं शॉप की तरफ ऊपर से ये और इसको मैं नीचे रखना
ठीक है चलिए हो गया एक्सपोज. Suppose we
Enough, we have.
yes.
So first I'll try to see if I can.
So in a normal subject, what do you find by doing this?
I shouldn't be able to look through to the opposite.
You are not seeing anything. Huh? So there is no, normally there is lordosis, but when you lie down supine, then it is flattened. You cannot see. If you can see, then suspect there is some flexion deformity. Then what will you do?
Then I want to palpate and check. First, I'll try to insinuate my fingers between the spine and the couch. If I'm after assessing that, my fingers right now are crossing through the spine to the opposite side, sir. Then I'll ask the patient to flex the unaffected hip. Up one side.
Which is affected? Right one is affected.
Right side. So, there are pencil moving. Yes.
How
So,
much?
नीचे रख, जितना हो सके.
How much
Only
flexion?
until I'm able to not insinuate my fingers first. So I have to keep checking while flexing.
No. your hand is already underneath the spine, and then you ask the patient to flex the normal hip. Then fully you have the normal hip has to be fully flexed
Flexed.
because you want to lock the pelvis
Yes.
in that position. So your hand will remain beneath the spine. The fully flexed normal hip will lock the pelvis. Then you will start the homostasis. Okay. Then ask the patient to hold the normal hip in the flex position.
After this, I will place my goniometer at the greater trochanter.
No, no.
Don't need goniometer. You just assess 10 degrees, 15 degrees, it's good enough.
Suppose what Dr. Jain is doing, this is the position. So this is the position means how much is the angle from the ground to the of the thigh.
That will give us the amount of the fixed flexion deformity. Yes. One hand is here, sir. Along the shaft. Yeah, just tap it slightly first. Yes. Right. Okay.
Try to push it so that actually patient may voluntarily can break it much more,
Okay.
which to know that space it and maximum beyond that it will not be done.
Yes. Fine. The other hand. Yes.
To like the whole pelvis might be as Sarah said, to lock it. And one more point is that we see that this ischial reversal, it should not be much elevated for that.
Okay.
It should be.
For the pain. Yes. Sure.
Someone for telescopy. We're talking about non-union.
ठीक से लेट जाइए हो गया. Any other person for the telescopy? अरे जल्दी आ जाओ यार, वैसे देर हो रही है.
So for telescopic test, the hip it should be painless. The range of movement at the affected joint is up to 60 to 90 degrees, and at least 10 degrees of adduction is possible. Then we will do the telescopic test.
Why adduction is required?
So up to 10 degrees is permissible. So that
Why adduction is so important for eliciting telescopy? Hip is okay. Hip flexion ideally should be 90 degree. It should be 90-90 position. But beyond, 60 to 90 you can take. But naturally, I don't feel if there is any need of adduction must. Adduction must is not.
It is not, I have never read it, but of course in an abducted hip it is difficult to demonstrate, then a little bit of adducted hip. That's, I take the point that it is like that.
What? Yes. What you will do?
Should explain. Okay, he's done it.
so we will expose the patient adequately.
हो गया expose, हो गया.
Sir, then we will place the right hand below the knee joint and hold the both femur condyle and fix.
Yes.
And then we place the thumb on the ASIS, middle finger on the GT, and the index finger is in the perpendicular line. And then fix the pelvis. and then sir adduction. Then sir we will do sir 90 degree of flexion, and then up and down movement will be appreciated. If there is in this there is no practically sir, if there is
No.
continuity,
What
Sir,
you
up
are
and-
feeling? What you are feeling? He's asking.
sir, we feel the sir up and down movement, the translating movement in the sir shaft of the femur and the neck region.
No.
Movement of greater trochanter you are feeling actually. Greater trochanter is moving up and down if hip is not in the socket or the neck is absorbed.
When
These are the two
telescopy was described, it was described for dislocations of the hip joint. Okay. Ideally, you are seeing whether the head is moving with the thigh or not. But in, as Dr. Ashish has said, you can also examine the movement of the trochanter. So what he is asking, what structure you will feel? You will see any mass in the gluteal region or the movement of the trochanter. This should be the answer. Okay, the movement of the thigh.
Particularly the hand, it will feel the trochanter is going down, and when you pull it, it will go up, and you will feel with the finger that movement you will feel. And if you put your thumb on the hip, and this will let spine and tip of the greater trochanter, then a distance. It will be short, it will be long. While you're pulling it, so this movement, push movement.
So you are pulling and pushing. Which is more important? Pulling is more important and pushing is more important. What you see?
Pushing is more important.
Pushing is more important. So this is important. They were asked what is more important, pulling or pushing. Pushing is more important.
Yes, sir.
So next case presentation. Yeah.
Good morning to the chairpersons, the teachers assembled over here, and the students. Basically, we all are students. We are all are students. You, me, all you are students, except you have to sit for an examination. That is the only difference. We all learning of the book. May I have the pointer? Because I want a interactive.
ये क्या पढ़ा रहा है?
मेरा जो है ना वो डालिए So there are young students and there are MS students who are gathered from here, according to your raised hands. So slight difference is there between a practical examination between DNB and MS. I think DNB is much more tougher examination. You get at least 30 minutes time for 3 short cases in MS for examination. So there are basically 3 aspects of it. One is gathering data by your clinic history taking, etc. Then analyzing the data in your mind and presenting that data during the discussion with the examiner. Analyzing तभी आएगा जब तुम्हारा preparation ठीक से हो. पहला preparation, not in the examination hall, but preparation for 3 years, right? So how many of you have seen a osteomyelitis case? Only 2? No, not all of us. Almost all of us. Okay. Now they are afraid that I'm interactive, so I'll go to them and ask questions. That's fine. So osteomyelitis can be presented in various forms, right? In examination hall, usually they are short cases, or for DNB examination, they're case. So what do the examiners expect from you? That is most important, that you have to think about. Being able to take relevant history. You have gone through Professor Mina's lecture, Professor Rai's lecture, and Professor Pal's lecture. not to miss the general features. Even if, if it is a chronic osteomyelitis, you must not miss any relevant general features. Then, of course, systematic general examination, regional examination, and then focus on to the local part, right? And we expect when you are presenting, present in a coherent manner, sequential also. Always be after A, not before that. Arriving at a working diagnosis. We are expecting you to have a working diagnosis, not the final diagnosis right then, right there. And alternate possibilities. One more thing. This was allotted about 25 minutes. So because of paucity of time, I have set this timer on only 20 minutes. Okay, I'm starting over here. So whenever the buzzer starts in my pocket, I'll stop, right? Okay. Then we have to consider about alternate possibilities. We call these differential diagnosis. The examiners may ask what else it can be. And if there are something else, then you have to have points in favor of your diagnosis, pros and cons, I mean, plus points and minus points, and then same to the differential diagnosis. And the knowledge about the ethiopathology and management as a theoretical discussion one-to-one with the examiner, right? So these can present as swelling plus pain. Theoretically, may not be a chronic osteomyelitis per se on looking at it. So there is a difference. What is a chronic osteomyelitis? I'm going to, how do you define chronic osteomyelitis? Sit down, sit down. It's a sit-down comment, not a stand-up comment.
So chronic osteomyelitis is a sequence of acute osteomyelitis where there is bone death. Yes. So characterized by chronic discharging sinuses, extrusion of bone fragments from the wound.
Those are signs. Those are the signs. If they are present, then it is an sorry. So everybody agree? The examiners also agree that if you get these things, bone chips coming out, discharging sinuses, etc., it is a chronic osteomyelitis. Everybody agrees or not? Because we are testing the examiners also. This is not the only thing, right? Sine qua non. These are not the only sine qua non. Excellent. So, sir has given us a clue. Then, it can present as a swelling plus pain plus sinuses. So, if you get sinuses, your focus will be on the sinuses also, whether those sinuses are coming out from the bone. Those are coming not from only from the soft tissue, but they are attached to the bone. Now you tell me how to examine whether the sinus is attached to the bone or not. How do you do that? This is relevant or not? Relevant, so sinus has to be fixed to the bone or attached to the bone. So how do you do?
Probe. I use a probe.
You use a probe, but in examination hall, you do not carry a probe. You have all the instruments listed by
I see whether the sinus is attached to the underlying structure or not.
How? Clinically, how do you examine?
By palpation, sir.
By palpation, by pressing on the sinus?
No, sir.
Okay, how?
Area adjacent to the sinus that we do normally for the...
Area adjacent to the sinus? You press around the sinus?
Yes, sir.
Okay. Now you see, a perfectly wrong answer is perfectly acceptable here because we were not in examination table, right? But anybody want to modify this? Clinical examination of a sinus, whether it is attached to the bone, he has told that press on the sinus, not accepted. Press around the sinus, not accepted as well. Bolo? Bolna padega.
So can we go for mobility of the tissue around the sinus?
Mobility of the tissue around the sinus.
Or even including the sinus?
Yes. So sometimes, because this is a very superficial bone, skin, then bone mostly, so sinus is very fixed, and sometimes you get sinus on the thigh, where there is a layer of fibrous tissue and skin, subcutaneous tissue, then muscle, then there is a sinus. Then you have to palpate for the mobility. So how do you demonstrate mobility? Because these are the small points that examiner will harp on. Small point.
You have to hold the skin around.
Mic पे बोलो, सभी सुनेगा.
You have to hold the skin and longitudinal mobility.
What? Okay. So he is basically pinching the sinus and moving it sideways in long axis to the long axis and in the transverse axis. Okay. Accept. Sir, accept. Do you accept that? Do you accept that? Any incomplete answer, right? So complete the answer, Professor Pal.
Sinus may be fixed to the underlying muscle or fixed to the underlying bone.
Yeah.
So we have
May
to
not be
see.
coming from bone.
Yes, you have to see the mobility. Yes, you have to hold both the side of the sinus. You have to move in both axes. Along with the, we have to see the contraction of the muscles underneath. So irrespective of the muscle contraction, if it is not mobile, so on an attempt to do movement, its puckering is increased. That means its base is attached. Okay. So in both axes, if it is puckering is increased on attempt with this, it is irrespective of muscle contraction. So that is, it is fixed to the bone. But if it is a mobile in one axis, or its mobility is initially it may be present, but it is reduced on muscle contraction, that it is fixed to the muscle.
Thank you, Professor Pal. So while Professor Pal was elaborating, I have changed the slide. The patients may present, the cases may present with these discharging sinuses and maybe ulcers, right? So there are differences between these two. Can you tell me the difference? The conceptual difference. Of course, one is a lower part of the thigh, this one is around the hip. So what do you see, inspect around that area? On the left picture, inspect the finding.
There is a bulging sinus around the hip joint with a healed scar around the sinus. Two scars around the sinus.
A heel scar.
Scar.
What kind of scar?
Hypertrophic scar.
No, the disposition of the scar. Patient's head on the lateral side, patient, on the left side, patient's leg on the right side.
Anterior.
So it's a
Yeah.
longitudinal scar.
Longitudinal scar. Yeah.
Longitudinal scar has came there from what? Can you suspect what was done there?
Surgical scar.
Surgical scar. Yeah. So surgical scar is on the left side. Here we may not find any surgical scar on the right side picture. Right? So there is a difference. It may be a post-operative case. That may not be a post-operative case. Then your job becomes easier. Patient presents, your case presents with exposed bone. One exposed bone may be slightly different from the other exposed bone. What is the difference between these two bones exposed? I admit, but difference is there. What difference?
Granulation tissue is there, sir.
On which left side or right side?
Left side.
Left side. Right side?
It's necros. Slough.
So, Swanendu, what is the difference? No, got it. We haven't seen those cases.
I have not seen the case. One is that if you go to the left side, you see both the slides are having the necrotic bone. Yes. One is the active infection is present. That's why this granulation. So if you see this red granulation along with the yellowish margin, then that is a active infection is also there. Now, if you go to the right side, though the bone is exposed, but still there is no active discharge and the is almost puckered soft tissue.
Thank you.
So this is the difference.
In one, the so-called superstrum is separated, and in other, apparently it is not separated. It is not free.
So on the left side, the bone is coming out to you. Maybe 2-3 days later, the patient would have brought that bone in your chamber, right? Okay. So this is another type of presentation. Sometimes the patient presents with pain only, and then you find something, right? What is the most likely finding you can have this later? Patient only pain, but you find something else. Limb is there, X-ray is also there. What is the most remarkable finding on the left picture? Then, this is normal limb or what?
Sir, no, sir, it is
Normal lag raha hai ki abnormal lag raha hai?
normal.
Abnormal lag raha hai. Fantastic. So what is the abnormality?
Sinus is present.
Sorry, जोर से बोलो ना, mic है.
Sinus.
सभी को सुनना है. Sinus लग रहा है.
Yeah.
Sinus देख रहे हो. ठीक. Patient may
Sinus
not
and
be
redness.
bothered about those patient presents with pain. If the patient presents with pain, then you also expect on your examination there will be tenderness. So pain and tenderness along with these kind of picture signifies what?
So there is a thickening and irregularity on palpation.
On the in the X-ray, yes.
On
Plus
clinic,
pain, plus tenderness. So, what is the problem? What is the problem here? In difference to the other cases. So sometimes pain may not be there, tenderness may not be there, and sometimes they can be present in your case. So there is a difference. You have to make out the difference. Not all the questions will be answered right now here, because we cannot proceed then. Then patients can come with a deformity. If the deformity is there and you get a scar, you take history. Okay, history taking is much more important, always important, but much more precise over here. What are the many points you will ask the mother, maybe, but the child is not knowledgeable enough.
Any trauma?
Any trauma? Very good.
Any surgical procedure? There is scar marks. And there is any pus discharge previously?
Discharge only or something else also? How does it start? First we got an answer that it starts with an acute osteomyelitis. Mostly yes. If it starts with an acute osteomyelitis, what was the relevant history points there?
Is there pain and fever?
Pain, fever
and swelling of
swelling, because this is a very superficial area. Pain, fever and swelling.
Yes.
हुआ था कि नहीं हुआ था? हो सकता है 3 साल पहले हुआ था, 5 साल पहले हुआ था, लेकिन हुआ था कि नहीं? That is important. Because sometimes you have to differentiate between congenital something and those secondary something. So if the patient presents with deformity as a sequelae, then you have to be thinking about not only about the disease itself, but how to manage that. Right? So, some other cases, for example, periprosthetic joint infections, exposed implants, infected amputations. These are the various presentations in your examination, in your clinical scenario also. Ring sequestrum. How else can an osteomyelitis patient present? That is a more of a theoretical question, not a practical kind. Pathological fracture cases will not be given as a short case in your examination. Concurrent septic arthritis, ये हो सकता है. Concurrent septic arthritis, yes or no? हो सकता है. So, where do you expect and why? We expect chronic osteomyelitis leading to septic arthritis. When and what? Where? When and where? Okay.
Knee joint.
Only knee joint?
Knee and hip joint.
And hip joint, why?
When metaphysis intracapsular.
So metaphysis is intercapsular. Why metaphysis? Because the metaphysis is the common site of starting of osteomyelitis, right? So these are the things. Come to this. We already have covered that fever, swelling, pain, etc., and now you see this. X-ray will be taken out. Okay, and in X-ray, something has to be shown to the examiner that this has happened, this is there, this is this structure. So this is tumor. Now you tell me with the pointer. The pointer is here. Okay, sorry. Pointer is this one. Pointer is working. Very feeble. Oh, pointer is very feeble. So can you tell me where is the involucrum? Can you tell me where is the involucrum? Pointer better also. Radiolucent. Involucrum is radiolucent. How many people agree? Nobody agrees. Involucrum cannot be radiolucent, right? And the sequestrum, is it radiolucent or radiopaque? Radiopaque. Sequestrum is radiopaque, and No egos. Everybody have got wrong answer. हाँ, होता ही है. So sequestrum and involucrum both are radio opaque. Otherwise you won't. Okay. Only radiolucent thing is the जो छेद होता है उसमें जहाँ से पास निकलते हैं उसको क्या बोला जाता है? Cloaca. Cloaca is radio. So we are almost at the end of our basic thing about osteomyelitis. You know everything about the theory of osteomyelitis. Collectively, you know more than us. Collectively, individually, maybe slightly less. So practice on those things. I think I should stop over here because time is over. Right? Thank you.
Okay, thank you. There are many questions which are related with the chronic osteomyelitis has been covered. Any other question if you are wanting? 3-4 points I want to highlight for the PGs, if you allow me. If examiner asked what is the diagnostic features of chronic osteomyelitis, making a diagnosis clinically, then your answer should be the thickening of the bone, number 1, the irregularity of the bone, number 2, the presence of a sinus which is fixed to the bone with or without discharge, and history of bone coming through that sinus. These are the few points which are said to be the diagnostic clinical features of chronic osteomyelitis. Sorry, yes, the question is whether tenderness is a salient feature of chronic osteomyelitis. I would say chronic osteomyelitis does not have tenderness. If tenderness is there, there are several reasons of the tenderness or the pain. One is the acute on chronic, that is acute exacerbation of the chronic osteomyelitis. If the sequestrum is hurting the soft tissue, such as muscles or the nerves, then the pain and or the tenderness can be there. Number 3 cause is the presence of pathological fracture. These are the features, these are the reasons in which you may be associated, the chronic osteomyelitis may be associated with pain. And what are the causes of diphysial chronic osteomyelitis? As Dr. Saab has said that it is mainly metaphysial. What are the diphysial? The causes of diphysial, 2 minutes more. Diphysial chronic osteomyelitis is post-traumatic or iatrogenic or tubercular or pyogenic में salmonella. These are the 4, sorry. No, I'm asking if examiner will ask what are the causes, you will say whether it's a child or the diphysial are only 4 causes of diphysial. Any age group are these 4 causes. Then he may ask the complications. So a complication of chronic osteomyelitis, if the child, if the patient is of growing age, you have to see during your examination any associated angular deformity. You have to examine for angular deformity. And of course, the types of sequestrum is a theoretical question which may be asked sometime by some examiners. Thank you very much.
Regarding osteomyelitis, very often we ask the students that what are the common complications. Like I have already said, that is a lengthening, deformity, or shortening, and you'll have to explain in that way. Okay, and stiffness of the neighboring joints. These points should be kept in mind.
And amyloidosis at the end, you must remember. Whatever it is, but one has to speak. Like syphilitic osteitis, I have never seen. But for a diphysial reason, syphilitic osteitis is one of the reasons you have to speak. So I will speak about the examination of the knee. Again, a very vast topic. 30 minutes have been allotted. I will just run through. There is a dummy patient also, if you want. I've seen that. I've seen it's the same one. I've seen that. So Just I will go through. So whatever videos are there inside, they can explain many of the tests. So just let me run through because it's endless thing. You cannot summarize in 20 minutes of 15 minutes. So history taking, again, it has been discussed again and again. What mind doesn't know, eyes cannot see, and eyes cannot see, hands cannot demonstrate. So it's very important. You should know and make a presumptive diagnosis. I use the term presumptive diagnosis with your history. What is the problem? Trauma, tumor, tuberculosis. These are the three major things that we keep on talking again and again. What is the reason? If you get a tumor of the distal femur or proximal tibia, then things are very different from IDK, where you have a instability. So examination also cannot be summarized for both of the things altogether. It will be a very huge topic. So we cannot keep on talking and just talking. So I will just skip so many things. But it is there that complaints, you must start from the complaints. Then only you will restrict your examination to that part only. Otherwise, you must see these major complaints. For pain is coming, swelling, stiffness, locking, deformity, feeling of giving way, instability, limp or loss of function, or the combinations. So accordingly, you have to plan your examination. Otherwise, it's very difficult to, again, everything has to be explained. If it's pain, then you have to keep on explaining swelling from where it is coming. Accordingly, you have to modify your examination. Okay. If, if deformity is there, then again, so many reasons: varus, valgus, recurvatum, flexion, triple deformity of the tuberculosis, bizarre deformities of Charcot joints, or the hemophilic broadening of the bones. So these, when you find all these things, accordingly your examination will change. When we talk about the locking, the meniscal tear, loose body must come to your mind. Laxity, ACL, PCL, MCL, LCL, or the combinations, they must come to your mind. And your examination restricts to the stability of the ligaments you have to look for. Limitation of movements or stiffness, it is painful or painless. Accordingly, there are so many reasons and your examination has to be modified. When we talk about the physical examination, it is very important, develop a standard routine of examining so you don't miss. Elevate the patient's fears, so explain beforehand what you are going to do. General steps are inspection, palpation, range of motion, measurements, strength of testing, strength of muscles, and the special tests. Again, it remains the same, but you have to modify as per your presumptive diagnosis. Exposure is very important. From going to the toes is enough for the knee joint as far as it is concerned. Inspection, both knees simultaneously to be inspected from front, from side, from behind. So accordingly, you will find whatever is there. Quadriceps muscle mass is very important. It is lost in each and every case of concern with the knee, maybe ACL, maybe osteomyelitis, maybe any damn thing. Position, shape and size of the patella. Again, patella is one of the very major important thing you will get in your exam. Recurrent dislocation of patella. It's very important thing. If you have a in your wards, you will get it. Patellar ligament, you have to look for superior and infrapatellar foci, tibial flares, tibial tubercle. So any skin changes, these all things you have to inspect as we are discussing in the cases beforehand also. You must know the anatomy, then only you can see what is normal, what is abnormal. In flexion, in extension, you have to look for. So just let me run through because you all have read it, you all know it. We will stick to the important things only. So attitude is something which is being asked for us. It is the attitude of flexion which is there. No other attitude I have ever seen in the knee joint. It is the attitude of flexion. Anything is there, knee is flexed. So alignment, genu valgum, verum, windswept deformity, or whatever is change in the alignment, you have to see in the standing position. Look for front, look from behind. Sometimes you may find something like popliteal cyst, which is a normal thing. Many times you will get the Mohren-Baker cyst. So you have to look for all these things again and again. From sides, from front, I will just run through. You must know the surface anatomy, which structure is where. Then only you can find which is not normal. So let me run through. Gait. We have discussed a lot about the gait. So for the hip joint, gaits are different. Antalgic gait, Trendelenburg gait, Waddling gait. If you know all these three, enough. No need to know more about the gaits for orthopedics as such. But when we talk a little bit for the knee joint, we talk about the valgus thrust gait or the varus thrust gait. If I am asked to speak about the knee, I must speak or point out these varus and valgus thrust gaits. Like just you can see there is a malunited or hypoplastic type of due to injury only, the femoral condyle you can see, and on the medial side it is like that. Common thing with the HOFA fractures you will get. And just one a clip, you see, I just opened up my mobile and recorded. Just see how this lady is walking. So with a valgus gait. Similarly, here you can see malunited tibial condyle, medial tibial condyle. Again, you can see this gentleman where it looks like there is LCL, but it is because of the bony deformity. This kind of movement is there, and you can see how this fellow is walking again with the valgus gait. So when we talk about the knee joint, you must know these are the gaits concerning to the knee joint. Patella is a very important thing. You have to examine the patella in sitting position. You must know what is Insal-Salvati score, and accordingly you will measure the length of the patellar tendon and the length of the patella itself, and you must know they are almost equal, 1:1. For the X-ray finding, there is modification where you are measuring the articular surface, and it is 1.2. Tendon is longer as compared to the articular surface of patella. So it's very important to speak about patella baha or patella alta, high riding or low lying patella. So again, you can palpate all these things. One thing very, very important where I have to stop, the fluid in the knee joint. It's a very common finding, and you must know how to examine for the minimal fluid, moderate amount of fluid, and the maximum fluid, tight fluid. So if you have fluid filled with knee joint which is going to the popliteal fossa also, means it's a tense effusion or tense whatever fluid in the joint, then it's a moderate amount, and you can extend the knee fully. Then you can demonstrate the patellar ballottement or the patellar tap. So you must be able to demonstrate, and examiners are very fond of asking if there is flexion deformity. Can you? I cannot. With the minimal fluid, you have to examine in the standing position and see the infrapatellar fossa which are getting filled up or not. So fluid in the patella or fluid in the knee joint is important thing for the examiners to ask, and you should master in telling this. Difference between the hemarthrosis, pyoarthrosis, synovial thickening and synovial effusion. So you must be able to speak about something. It's a theoretical thing, but you must know whether it is blood, it is pus, it is or simple straw-colored synovial fluid. Should be able to speak out. Where to feel for the synovial thickening? Again, in the suprapatellar pouch, you can hold the skin with the extended knee, relax, and you can feel and compare from both the sides. Or at the insertion of vastus medialis, that's the area, because vastus medialis is getting wasted at the earliest, responsible for the terminal extension of the knee, which you lose the very early point. So you can feel the synovial thickening at these 2 points. Examiners are very fond of asking. Just remember this. Then these are the special tests regarding patella. So patellar grinding test, you must know. Recurrent dislocation of patella, you must know the J sign or the Sage's sign, that is telling you the laxity of the medial lateral laxity of the patella, and patellar grinding test and apprehension test. These are the important things, and these are the various correlations why you develop these kind of patellar grind tests. Like these are the problems, you will have the positive grind test. This kind of problem, you will have a patellar grind test. And this is the apprehension test. It's a laxed medial patellofemoral ligament. So you should be able to demonstrate tight lateral structures of patella or the lax medial structures of patella, which permit more movement or less movement on the either side. So these are very important for the management point of view as well, and for the exam also. Q angle is very important. Quadriceps angle, you should be able to measure it, draw it, and important that you are drawing it at the 20-30 degree of flexion of the knee. It's very important. So your patella is fixed into the notch and you are marking it from the AS down to the center of patella, from center of patella to the tibial tuberosity and going back. So you draw this Q angle. So in a genu valgum, Q angle will be more. Genu varum, it will be less. So you should be able to speak about the Q angle. So it is more than 20 degrees, it is abnormal and provoking for the lateral dislocation of patella. So Q angle is an important point. You should know how to. Palpation, again, you have to feel for the joint line tenderness. It's very important for the knee. Pes anserinus, you should know where it lies. You should palpate for it. And the medial collateral ligament, both femoral and the tibial attachments, you should be able to palpate. In flexion, it is easy to palpate for the joint line because ITB band is displaced and you are able to palpate it like this. So you are feeling for the collateral ligament on the medial side and the pes anserinus like this. Lateral side, you have to palpate for the ITB goes back as you flex and you can feel for the lateral joint line. It's important in the palpation. Posteriorly, we have already discussed. You should go for it. Range of movement is very important. So we know normally 0 to 135 degrees the accepted range from full extension to the flexion of 135 degrees. So you should be able to measure it, compare from the both the sides and speak like this is short of 5 degrees of full extension. The range of movement is from short of 5 degrees of full extension to this much of flexion range. So it is important to speak about the range of movement. Certain things can stop this from full extension, like this is the locking and unlocking important video. See the medial meniscus popping inside and with your maneuver it can go outside. So your knee becomes again free. Again with some movement it comes inside. So you must understand what is locking where full extension is not possible, although you can flex the thing. So this is locking, unlocking, or there is some bone block inside that can prevent from full extension. So these are the conditions when we talk about the knee, which is not a tumor or not an infection. Measurements, again for the quadriceps you are going to measure. You must, from the joint line, you should speak this much centimeters above the joint line. I am going to measure for the bulk of the quadriceps, not from the patella, because it's a mobile structure. Stick to some joint line from this much, compare from the other side. If it is more than 2 centimeter difference, then it is important quadriceps wasting. Strength of the muscles, there are 2 groups only, extensors and flexors. So you can measure at the 90 degree of flexion, you can measure how much is the strength for the quadriceps in extending the knee or the hamstrings in flexing the knee, and you can even measure them with a spring balance or something like that. But for PG exam, it is just the strength, whether it is grade 5, 4, 3, what is it is. Then patella apprehension test. We are trying with the extended knee. You are just trying to dislocate it laterally. Patient is apprehensive or it actually dislocates. That will be the special test for patella. Habitual dislocation, on flexion it goes, on extension it comes back to its groove. That's a habitual dislocation, or it can be permanently dislocated also. Instability, this is the point where we have to stop and talk something a bit specific about the instability of the knee joint. Nowadays, we are getting this kind of cases in our examinations where ACL is torn or PCL is gone or something like that. You will get these cases now. Previously, at our times, we were not getting. But now, because so many arthroscopic procedures are being done, so always there are patients available in the wards and you may get them. So one plane instability is basically for you people, nothing more than that. So anterior-posterior or mediolateral. These are the 2 things we all know, the 4 major pillars of the knee, ACL, PCL, MCL, LCL, along with some other supporters. So you should know the anatomy, but I will just rotatory instability and the combinations, they are the other things. So one plane anterior instability, that's a ACL injury basically. So you should always know that tibial margin in 90 degree, you just examine the femoral condyle anterior surface and the tibia anterior surface. So 2 millimeter anterior is normally your tibial margin. Normally it is 2 millimeters anterior to the femur. That's the thing. That's the normal. You must understand. So if you do this test and you find it coming more anterior, then it is anterior laxity or anterior instability is there. Then when you try to pull it anteriorly and it stops with a hard end point, then it is a partial injury. And if you don't find any hard point and you just keep pulling, it keeps coming out, or mushy end point, the other fancy name. So means a complete ACL tear. So you will get these ACL cases very frequently in your wards and they are given in the examination. So a positive test, increase anterior tibial translation over 6 millimeter. How much anterior translation is there, that you have to see. Positive test indicates ACL injury, lateral capsule, medial capsule, MCL, but just remember ACL. False negative is also important because if PCL is injured, the tibia is sagging behind, you correct it to the normal and it looks like that you have an anterior drawer test positive. So it is important to remember that normally 2 millimeter tibial margin is anterior to the femur. Then only you will understand that it is a false one or it's a real anterior drawer test. So this is at 90 degree when you do it is anterior drawer test, and at the 10 to 20 degree flexion when you do it, it is Leishman test. It is more sensitive. You can more properly demonstrate with this the anterior instability as compared to the anterior drawer, but you must know both the things. So a small video, because patient is not having the real thing. Oh. So we can. So in 90 degree, I'm just trying to do the anterior drawer sitting over the foot of the patient, stabilizing it at the 90 degree. 10 to 20 degree, you just see the Leishman, how freely it is coming anterior. So it's a complete ACL tear, like this kind of anterior migration in the Leishman test. So anterior drawer, again you can see anterior drawer is also coming. It's a light patient, so it is coming overall also, but you can see. Then pivot shift test, fancy test. Normally every time you cannot demonstrate it, but you must know how to do it. So pivot shift test, you hold the heel of the patient like this, give a valgus strain over the knee and just extend it from flex position. You can see flexing, extending. Just flex and you just see what happens. So not classically demonstrated, but it is part of examination under anesthesia. Normally we always do. Just see what is happening. So the pivot shift, the name pivot is at the Jerdis tubercle where ITB is attached. So ITB, we all know iliotibial tract is flexor at 30 degree and extensor less than 30 degree. So it changes its axis. So normally the tibia is anteriorly dislocated. When you start flexing in extended position, tibia is anteriorly subluxated. ITB is just extensor at this point. As you flex it with the valgus, the ITB becomes flexor after 30 degree and it relocates your tibia back to its position. So anteriorly displaced tibia goes back to its position. This is the pivot shift test. And this pivoting is the reason why patient comes to you. Not for the Leishman and for the anterior drawer. He is coming because of the pivoting problems. That suddenly my knee gives way. So pivot shift is important. Reverse pivot shift is for the PCL, more difficult to demonstrate, and normally it is not common thing to be asked with you in the examination. Varus and valgus stability is for medial and lateral collateral ligament, very important, very common, and you must rule out the bony problems like that. A malunited femoral condyle or tibial condyle can give you a false varus or valgus test. So we are talking only about the ligament, where if you give a valgus stress, it is testing your medial structures or MCL mainly. You are giving a varus stress, it is testing your lateral structures or the lateral collateral ligament and the other supporting structures on the posterior lateral corners. So we are talking about the one plane instability, test varus and valgus at 0 degree and at 30 degrees. So at 0 degrees, if it is medial lateral unstable, things are more severe. At 30 degrees, it is mainly the collaterals which are supporting. So if you are having positive varus or valgus test at 30 degrees, it is mainly the collateral ligaments. If it is coming at 0 degree also, means capsule is gone and other supporting structures are also disturbed. So do it at 0 degree and 30 degrees. Combination of MCL and ACL and PCL is there. So just a small video. You can see, compare from the other side, movement is more, MCL is injured. So like this, MCL is injured, just correlating with the figures. So MCL is gone, joint is opening up. The same thing you can have a stress view also. The same thing you are doing and taking the X-ray, that will show the joint opening more as compared to the normal side. So a joint which was mobile like this before the surgery, and after the surgery it is stabilized. Your medial supporting structures are now intact. Similarly, for the posterior drawer, PCL is injured and the other structures on the posterior side, when they are injured, you will see the posterior drawer. So the first sign is the posterior sag sign, sagging at the patellar tendon. You will see the sagging behind of the tibia, and the prominence is gone like this. You can see, you can examine like this also at 90 degree. You see this sloping. This gives the posterior sagging of the tibia or the PCL injury. Posterior draw test at the 90 degree, sitting over the foot of the patient, and we are just performing the same test. You just see it goes back like this. It goes back. So this is for the posterior draw test. Quadriceps active test. This is the loss of contour of the patellar tendon, and as you ask the patient at 90 degree to just tighten his quadriceps, and this disappears. So this is quadriceps active test. So once anterior posterior instability, patient may come to you like this. They can do like this. With their hamstring tightening, they can take it behind like this, and the quadriceps tightening, it comes back. So you can see the quadriceps active, how it brings back the posteriorly subluxated tibia. If you examine this anterior drawer test in external rotation, 30 degree of external rotation, you do the same anterior drawer test and you see the medial side coming out. This gives the anteromedial instability. You do in 15 degree internal rotation, you do the same thing, and this will tell you about the anterolateral instability. PLC is important. You must know these tests, that we call it external rotation recurvative test. Just raise it holding the great toes and look for the more external rotation on the injured side of the posterolateral instability. So this is important. Recurvatum is there and there is more external rotation. This is for the posterolateral corner injuries. And the dial test, again, you can try this at the 10 degrees of more external rotation on the injured side. This is the dial test. You externally rotate a fully extended at 30 degree and the 90 degree, and you just examine the injury. A place compression test, a blind test for the compressing at the 90 degree, you are compressing the classical teaching, and you see, as you external rotate, internal rotate at this grinding, pressing down, you will see the meniscal injuries. If you externally rotate, you are looking for the medial, and the internally rotate, you are looking for the lateral. So these are just giving some idea, nothing more than that. But you must know McMurray's test is very classically defined. Go and read it out for the medial meniscus, anterior horn, posterior horn testing. You must know, but it's not very informative test. Still, you should know. A squat test, they are just grinding test of the other kind. Thesely test, again the same grinding test. So differential diagnoses are different by their age. Keep in your mind and examine your knees accordingly. And at the end, listen to the complaints attentively and have some idea what to examine. Make examination a habit and a sequence. Basic stability test needs to be mastered. Varus, valgus, anterior, posterior instability, drawer and Leishman. Don't jump over to the MRIs. Try to see yourself MRI plates. Don't read out the reports. Confirm your findings, examination under anesthesia. If any doubt, confirm from your patient during surgery also. This is for us, not for you.
Thank you, Professor Ashish. Any question? It's a very important topic, and PG must have some queries. If you have any confusion, please ask. If Dr. Ashish, do you want the dummy?
I don't think I've demonstrated everything. If they want to do it, then it is here. आ जाओ भैया लेटो
Good afternoon, everyone. So I'll be standing on right side of the patient. I'll explain the patient what I've been doing. So मैं आपका पैर थोड़ा मोड़ के आगे पीछे थोड़ा टेस्ट करूँगा. आपको पेन कुछ भी नहीं होगा. पेन होगा तो बता दीजिए. Okay. So if the right side is affected, first we would like to examine the opposite side. So first I'm going for the anterior draw test and posterior draw test. So for example, now if I'm examining the right side, we'll make the patient, we'll ask the patient to relax his muscles, or else we can get a false negative result. Okay. So once the patient has loosened the spasm or any voluntary contractions, then we'll keep the patient knee 90 degrees of flexion, and then we have to stabilize the femur from one side, and we have to stabilize the lower leg from the other side. One option is we can sit on the slightly on the foot so that this doesn't move, and one person, or we can ask the patient itself to stabilize his femur, and then we'll be feeling the proximal tibia just distal to the joint, and then we have to hold it with both the hands, and we have to check whether posterior draw is positive or not, or else we can get a false positive result. And when posterior draw is negative, then we have to try to translate the tibia anteriorly, and then we have to feel for the amount of translation. So as sir told, if there is more than 6 mm of translation, in such cases we might diagnose this as tear, and we have to also feel for the soft or the hard endpoint. So this is how we see for the anterior draw. In this patient, it looks like it's negative and ACL tear is not. Yeah, this is posterior draw where we are doing the posterior translation, and this I'm trying to do the anterior translation. And Latchman, we have to do this. We have to take the knee in 30-degree flexion. We have to hold the thigh with one hand and the leg with the other hand. Okay. Okay. And then same in 30 degree.
should be like 45 degrees, knee to 90 degrees. Then why you keep the fingers in the back? Because we have to see that the ankle is there. So that is the hard point that we remember. And fourth is that the foot should be big. So that's why you have to go to the leg like that, keeping the foot like that. So we do that up to maybe 45, 90, foot and hand. That's why you keep the thumb like this. And put the both the thumbs so that you can calculate the finger again and you know that how much medium is coming in limit the hand from the road. It is not like that. It has to be like that so that you complement the finger on one side. How much of the medium is moving from? So that I told you all we have already. But this is just for remembering that you don't need to put points and points.
30-degree flexion, we have to hold the leg, stabilize the femur, and we have to 0 and 30. So first in 0, we have to give a valgus stress, and then at 30 degrees, we have to give a valgus stress. Same thing we have to do for the valgus. I'm not sure.
Thank you very much, Ashish. So I'm going to start a very important short case, that is the CTV case. So I would like to present what question I asked from my during the examination. So I have prepared my presentation like that. This is the scenario: a 3 months old male baby presented in our OPD with deformed feet since birth. It was a first baby, full-term normal vaginal delivery. There was no associated abnormality as far as the history by the parents are concerned. There was no family history, the personal history of both parents as well as the antenatal history was what non-significant. So these are the points which you should ask or attend when you are you are examining any deformity, congenital deformity in a child. So this was the presentation. I mean, this is the deformity which is very frequent in your OPD. You all must have seen this. So diagnosis is, I doubt if there is any confusion. So diagnosis is congenital talipes equinovarus. The question next is asked, what are the other things would you like to examine in this child? So we have to examine the child as a whole subject. It's starting from, I would like to enumerate from, but I mean whether there is any congenital squint or not, the cleft palate, the cleft lip, the torticollis, any spinal deformity, any deformity in the spine, whether the heart is normally placed, dextrocardia is not there. The umbilical hernia you have to examine. You have to examine the direct hernia. You have to examine rule out the undescendant testis. Then whether hypospadias is there or not, epispadias is there or not, any other congenital musculoskeletal deformities such as CDH, CDK is there or not. And in spine, you have to rule out the spina bifida, occulta, and meningomyelocele. These are the things which you should be able to examine before presenting your case. Would you like to add some adjective in the diagnosis? Your answer should be yes, because it would be idiopathic congenital talipes equinovarus. Idiopathic because you are not able to find any other associated congenital deformity which is associated with this patient. So you would like to say that it's a idiopathic congenital talipes equinovarus. The points in favor are history of deformity present since birth, means congenital. It's a bean-shaped deformity of the foot with classical deformities, that is equinus at ankle, hind foot varus, midfoot cavus, and the forefoot adduction. The deep crease which are present on the on deep, these are the, you can see this is the medial crease which are present, and the posterior aspect of the ankle and the medial aspect of the foot. The lateral border is convex and medial border is concave. Heel is small, elevated, and the calcaneum is less palpable or is not palpable. And as we have already emphasized, no other associated abnormality present in the hip, spine, or the knee joint. So C for congenital, T for talipes. Talipes means talus plus pes, ankle and foot. E for equinus, and V for varus. This is the classical deformity and the presentation. If you will ask how you will classify the CTV, then CTV you will classify like idiopathic or secondary. The secondary causes of congenital talipes equinus are neurogenic, vascular, the muscular, and osseous. Osseous is the medial lower physis of the tibia is abnormal, absence of lower part of the tibia is there. Muscular is AMC, and vascular deformity, it is seen that tibialis anterior artery or dorsalis pedis is absent, and neurogenic as the associated with meningomalocele. What are the main joint which are involved are the ankle joint, the subtalar joint. Subtalar means talocalcaneal joint, and mid-tarsal is talonavicular and calcaneocuboid joint. The anatomical changes, it's a theoretical question. You must be knowing. You can read from the book what are the changes which occur. But sometime it is asked, what is the primary pathology? The primary pathology is shortening of the soft tissue. So bony pathology is always secondary. The primary pathology is soft tissue pathology in CTEV. One term is varus, one term is supination. Supination is combination of adduction, inversion, and plantar flexion. Okay. Sometime the examiner will ask you what do you mean by supination, because when you will manipulate the foot, then supination term will be used. The primary pathology is soft tissue pathology. The most important abnormality is cavus, followed by adductor, varus, and then equinus. Okay, cavus occur at midpoint, midfoot. The adduction of forefoot occurs at mid-tarsal mainly, and sometime it also occurs as subtalar joint. The varus occurs mainly at subtalar joint, but it also occurs at mid-tarsal joint. And equinus mainly occur at ankle joint, but it also occurs at subtalar joint and mid-tarsal joint. So all the deformities are occurring at all the joints. It is only which deformities occur mainly on which joint. The classical signs are small bean-shaped foot, small first ray. First ray means great toe, the first metatarsal, the medial cuneiform, the navicular, and the talus is the first ray. Small first ray, heel is elevated, tendoachilles is tight. The ratio between the calf muscle and tendon is reversed. Normally, two is the muscle, one is the tendon, but in this case it is reversed. The medial border is concave, lateral is convex, equinus at ankle, hind foot varus, midfoot cavus, and forefoot adduction. Sometimes the internal torsion of the tibia is also associated. So you must remember if somebody is asking, but it is not the classical deformity. So different terminology are being used. One is the resistant. When the correction is not obtainable, then it is resistant. The relapse, when all the deformity or any of the deformity has recurred after successful achieving the correction, is relapse. The recurrent, when one or many of the deformity is recurring, coming again and again during the course of the treatment. During the course of treatment, the relapse after the course, that recurring during the treatment, neglected. If child has started walking on deformed foot, then you will call it neglected. It is not that there is the time 9 months or 1 year or 2 years. It is the walking weight, starting weight bearing on the deformed foot. And postural foot is the shape of the foot is abnormal, but the classical signs at the medial crease, heel, first ray, these are not present in this case. That is postural club foot. So what is the role of, next question is asked, what is, how you will diagnose? The diagnosis is usually clinical. Any role of investigation, role of USG in less than children less than 6 months, there is some role of USG to assess the thickness of the ligament and the talonavicular joint articulation, and to assess the position of navicular medial malleus as they are not ossified. Then what is the role of radiology? Usually for the management, the X-rays are not required, but to quantify the deformity, sometime after 6 months, you may go for X-rays, and AP and lateral view is done. And in AP view, these are the 3 angles which are required. And these in lateral view, these again 3 angles are there which are required. This is more to quantify and more to I mean, during that course of that management, that too in the neglected type of club foot, the role of these radiology is there. How to define severity? By Pirani score. There are 2 type of, I mean, in Pirani, total is 6, minimum is 0. The hind foot contracture is 3 point, and the mid is 3 plus 3. 0 is the best, and you give either 0 for if no abnormality, 0.5 for the moderate, and 1 for severe. And other method of defining the severity is the ratio between medial border and the lateral border. Normally medial is 2, lateral border is 0.9, but it is reverse. So what is Pirani? We have already discussed, and maximum is 6, most severe is 6. What is the concept of Ponseti? The fulcrum is at head of the talus. Foot deformity is corrected in each cast. 2 equally important phases, the corrective phase and the maintenance phase, are there. And there is a kinetic coupling that the forefoot, if you supinate the forefoot, then the forefoot will be in line with the hind foot, and this is known as kinetic coupling. The percutaneous tenotomy is a salient feature of Ponseti technique. There is a specific protocol for as far as the bracing is concerned, and we have to go for long-term follow-up. The goal of treatment is to get a functional, pain-free, plantigrade, mobile, normal appearance, and chewable foot. Why it is said the Ponseti is best method? Because there are less chances of scarring, complications such as rocker bottom are less, the duration of plaster is less, and it is said to be more effective and cost-effective method of treatment. The first step of Ponseti technique is manipulation and casting in sequence. The first step you will do the supination, that is the elevation of first metatarsal, which will cover, correct the cavus. The foot will be more in supination. You will never evert the foot. You will do the abduction after doing the supination. And when your supination is corrected, then you will go for correction of equinus. So this is the cast. The first cast would be more supinated, more deformed than subsequent. So how you will differentiate between Ponseti and kite? The fulcrum in Ponseti is talus, in kite it is talocuboid. 4-foot deformity is corrected in each plaster application first. In kite, all the 3 deformities are being corrected. Percutaneous tenotomy only in Ponseti. Duration 1 week in Ponseti, 15 days in kite. So the total duration is lesser in Ponseti than the kite. Why kite methods fail? Because kite abducted the subtalar joint and he ignored the kinetic coupling principle. When you will do the tenotomy, percutaneous tenotomy, when the Pirani score indicates that the mid-foot Pirani score is less than 1 and hind foot is 1 or more than 1, and foot abduction is at least 60 degree of external rotation. What are the points, end points of the treatment? Abduction should be aimed at 60 degree, mid-foot score 0, dorsiflexion 10 degrees, Pirani should be ideally 0, but less than 1 is acceptable, and child should be able to evert and dorsiflex the foot voluntarily if you are striking the sole. The maintenance phase is by foot abduction brace. It has to be initially 23 hours a day. Then you will taper it out slowly, and it should continue till the age of 4 to 6 years. If patient start walking, then during walking you need not to go for abduction brace. Otherwise, it has to be for all the time. Abduction brace, if it is a bilateral club foot, then both foot should be at 70 degree in brace. If it is a unilateral, then abnormal foot would be 70 degree and 30 degree for the normal foot. This is the different type of commonly used is Steenbeek abduction brace, and this is the different type of brace, just for your information. What are the complications of management? Are the plaster sores, skin allergy, swelling? If swelling is there, then there is a concept of plaster holiday. Sometime if there is, you are not putting the above knee plaster till the high groin, then the chances of slipping of the plaster is there. If it is too tight, that the circulation may hamper. And if you are not doing the steps properly, then chances of rocker bottom foot are there. And of course, the recurrence is there. Most common cause of recurrence is non-compliance. The most common complication which occur is adduction and then followed by equinus. The common errors in the Ponseti are pronation or eversion. You should never do eversion of the foot. The kite error, that is, you should not push the calcaneum while manipulation, and you should never do the below knee cast and attempt to correct equinus before heel varus supination correction is another common error. When you will say it is a failure, if 3 Pirani score do not improve by 3 consecutive casts, then you will say your treatment is not improving. And how to manage the failure? You will start with Ponseti. You will do the Ponseti. The question is asked, why you want to, in a 4-year, 6-year age, why you want Ponseti? Ponseti is being done to stretch the contracted tissues so that the amount of surgery will be lesser. The osteotomy would be lesser. So you start with the Ponseti. Otherwise, this is I have given you an idea what are the different methods to correct the during the as per the age of the patient at the time of presentation. Thank you. Any question if you want?
There is no patient of CTV, so we cannot demonstrate, but it was a elaborative talk by you. And,
supination and varus. Actually, adduction, what sir is saying, adduction only occur at mid-tarsal joint. Varus occur both at mid-tarsal joint as well as subtalar joint. But supination includes all the three, including the plantarflexion also. So the whole component, all three components are there in supination. This is very common question which is being asked during the MS examination.
So tea is there in the hall, so feel free to take it and 5 minutes break in the hall. So stay in the hall and we can continue with the rest of the lectures.
Hello, hello. Be seated, please. Now we will go for the shoulder examination. Now I would request Professor Bhushan and Dr. Samanta, get plus ready. You have PPT, no? Some PPT. Dr. Bhushan, डाल दो. Shoulder examination.
And if he has to give you honors or a gold medal, he will ask you shoulder. So it is a double-edged sword. It can go any way. As you can see the list, much water has flown in the sea or the Thames. ये सारी चीजों की पढ़ाई हो चुकी है. I hope all of you understand Hindi well. You are from the Hindi heartland. So as you have read for last 3 years, I'll start with a शेर कि माना कि इस चमन को न गुलजार कर सके, बहुत आपको ज्ञान दे करके जबरदस्त तो नहीं बनाएंगे, कुछ खार कम ही कर गए गुजरे इधर से हम. We will take out some of the weeds. So I, with my senior colleague, Dr. Swarnendu Samanta, he was also contesting for the national president, and we are from the same eastern part of the country, and we are friends too. So as you go in the field, small field, there are grass, there is flower, there is weeds. You remove the weeds. We are here to remove your weeds. These things you have been told so emphatically, beautifully, in an elaborative way by all the previous speakers, nothing to do about it. Inspection, fine. You have to inspect the shoulder from above, below, front, back, side. Then palpation. As the patient's palpation is done, patient should be sitting, a scapula should be fixed, and do the palpation of all the structures you know. Shoulder has humerus, scapula. Lesser tuberosity, greater tuberosity, biceptal groove, coracoid, acromion. Fine, बस हो गया. Clavicle को feel कर लिया, बढ़िया किया. Yes, हाँ. Remove the shirt. खोलो यार. इसका इतना मस्कुलर कैसा है?
Don't forget to make the patient, remember this one, make the patient be seated on a stool, and then you see, just examiner will see your movement. Don't comment from this side. See, why sitting? Because you have to see the shoulder from the top. Understood? So just whenever the examiner is going to ask you, see from the front, limb should be like this, see from the side, see from the back, see from the top. Then because if every movement, the clinical examination is the most important. Theory might be poor. In practical examination, you are not going to ask much of the theory. Okay.
Right.
आप बोलिए ना, हाँ,
माइक है। नाउ अगर कहे कि प्लीज शो मी द coracoid, remember one more thing. Tell him to flex the elbow, do the external rotation, then you will be able to feel it better, right? For any bony prominence, you should pass through the soft tissue and touch the first bony prominence. Therefore, you try to feel the coracopetralis and short head of the bicep. Movement, forward flexion, flexion in the line of perpendicular to the scapula. So it is not here, it is slightly adducted.
This is the common mistake probably we have also done during our exam. Remember, whenever we show whatever test is done in the shoulder is always in the plane of the scapula. As because scapula is not exactly at the coronal plane, it is 30-degree oblique like this. So all the test, all the movement, whatever you see in the scapula, remember the scapula is 30-degree oblique from the coronal plane. That's why if you show, somebody asks you to show the forward flexor, you do like this, then you are not going to pass. The forward flex, as because the scapula is like this, so it will be like this. Then extensor will be like this. Understood? And if you somebody asks you how to show the abduction, if you show like this, then you are not fast. Understood? It has to be 30-degree oblique from the coronal plane. So if you remember this only one point, how to see the forward flexion, extension, and this is the common mistake I have also done probably in my exam, if I would have been asked to. But remember one point, that scapula is oblique, 30-degree from the coronal plane. Then everything, even when we discuss about the calf test, this is true for that also.
So translate and transport yourself to the pelvis. The way you make the pelvis square and do in relation to the pelvis, you remember that you have to remember the scapula. Keep the scapula in mind, either fix it or whatever you do, and then abduction here. External rotation and internal rotation. These two movements are done at the resting place and at the 90-degree of abduction. Both. Crossover twist for adduction at 90 degrees. So movement, if you have to demonstrate, you demonstrate it by the side and demonstrate it at the 90 degrees. Other than flexion and abduction. Now, when it comes to shoulder, you have to talk of the tests which are important. That is impingement, instability, rotator cuff status, and glenoid labrum integrity. So impingement.
Anybody can show, anybody just tell me what are the tests for the impingement, shoulder impingement. Just you tell me, any third year who is going to appear for that, you tell me. Anybody from this row? What are the tests for the impingement?
Any PG.
Anybody, just volunteer. This is not, because once you, even if you make a wrong answer, still it will be printed in your brain. You are not going to do the same mistake again.
You are PG, all of you, please come.
कोई बात नहीं, I know. This is a homely affair, no problem. This is not the exam. We are not going to give you any mark. Just tell the name, that one or two tests at least, for what you do for the impingement.
What is painful arch syndrome? Do it. Elbow should be extended.
Extended, yes.
Supinate. Yes. The pain will come. Yes.
Yes. So at the mid,
from this point to this point, there is an arc of pain. Then it becomes free.
Free.
Right.
Yes.
Fine. This is also known as, goes by somebody's name. Needs. It's needs. Impingement test. Sign. What is the difference between needs test and needs sign? एक आदमी बोलो हाँ.
Yes, yes, very good, very good.
Give the local anesthesia, then switch it off. It is needs sign. And usually needs sign is difficult to demonstrate, so we do the Hawkins Kennedy test, and internally rotated. Make it 90 degrees.
So remember this picture. Make it 90 degrees shoulder abduction, and also it should be forward flex like this. The elbow should be looking front. Understood? It is not abducted.
Actually, it is done from this side.
So that you will not forget, okay, 90 degree abduction, elbow should be looking front, then you suddenly just abruptly internally rotates. Why you doing that? Because you want to take the greater tuberosity just below the acromion so that the supraspinatus rubs again. So if the supras there is some tendinitis, then the greater tuberosity is going to rub the acromion and the patient will feel the pain. So this is the Hawkins Kennedy test, okay?
There is O'Brien's test also. Why there is impingement? What happens to acromion? Acromion is of three types anatomically. You should know that Bigliani classification, type 1, 2, 3, 3 is booked 1. If it is 3, chances of impingement is more. If there is any problem in the subacromial bursa, there can be an impingement. If there is something wrong with the supraspinatus, there can be impingement. Right? So there is fourth test, internal impingement O'Brien's test. This is a test which fits everywhere. कभी impingement के लिए बात करेंगे, कभी glenoid के लिए बात करेंगे, कभी आपको longus biceps के लिए बात करेंगे, acromioclavicular joint के लिए करेंगे. So anything around this, O'Brien will tell you. So if you do a single test O'Brien's test in your practical clinic, you will know that there is something wrong. Right? There is a difference between O'Brien's test and Job's test. Job में क्या करते हैं? स्कैपुला के डायरेक्शन में हाथ गया, हाथ नीचे किया, हाथ ऊपर उठाओ.
So basically, when you do the Job's test, the best way of doing it, you remember this. How I am doing? See my thumb. I am keeping my thumb like this. So automatically, both the thumb of the patient will be pointing towards the floor. Understood? Then the abduction should be at 90 degrees. In the plane of the scapula. As I told you, because it has to be the opposite of the from your coronal plane. Then keeping this thumb like this, put your two fingers like this. Then ask the patient to lift babu jab bata hai na, aap thoda haath upar dene ke liye koshish karo. Dhीरे से जांच नहीं करना है. तो ऊपर उठा लो. So there are three things you are doing. One is the abduction at the scapular plane 90 degrees, internal rotation pointing the arm down, and then you are resisting the arm and back. So these are the three things that you are doing. If the power is weak, obviously you will diagnose that there is some problem in the supraspinatus.
And in O'Brien's, what do? सीधा किया, हाथ को मोड़ा, 10 डिग्री और मोड़ा. सीधा किया, हाथ मोड़ा, 10 डिग्री.
So if you just put both the hands together and then you keep then if you just do like 90 degrees, internally rotate and then again put the two fingers like this and ask the patient to lift. This is the classic way that you will not forget the history of the O'Brien. Understood? So 90 degrees, internally rotate, 10 degree adduction and then put the hands touching, keeping the two fingers like this. So this is the way you look at it. So you will not forget how to do it.
This step, if you cannot perform outright, there is Codman sign. The hand will fall. Usually, Job says the hand falls, supraspinatus is gone. Actually, what happens? Long head of bicep, bows and gets attached to the supraglenoid tubercle.
right? Supra sput is also coming from that place, that is also attached around that place. It is all beneath the around acromion. So that particular area, and the acromion has acromoclavicular joint. So this area, if it is at fault, O'Brien's test is positive. And if O'Brien's is positive, probably there is something wrong, right? So if the patient is very intelligent, the patient will tell you कि हमारा सर कहाँ दर्द हो रहा है, यहाँ दर्द हो रहा है, यहाँ दर्द हो रहा है, यहाँ दर्द. Otherwise, usually patients are not able to locate. सर बस नहीं होता है. Always empty can. Can you empty it? Empty can. Now, for the glenoid labrum. Glenoid labrum is avulsed from the glenoid. कब पर आ जाएंगे ना? कब पर आएंगे? कर ही दी तक कब के लिए कर दो. क्या कर रहे हैं सर?
And remember this, by the side, it has to be fixed with the body and ask the patient to externally rotate against resistance. Understood? Some mind the button after activity. So if you do like this, then it is testing for the infra. And again at 90 degrees, and if you resist and ask the button, and this is for the tennis mind. Don't remember totally case, you are not supposed to be asked to, even you are supposed to get the confidence in the. And the fourth is the for the substance. So what is the main use of the substance? The elbow should be, remember this one, elbow should be in front of the formal. The wrist should be straight. The wrist, you put bubble attitude, the wrist should be straight. Then ask the patient to press the belly. And if the substance is insufficient or so, two things will happen. Remember, one is the wrist will flex and elbow will go back to the former place. So this is the classic picture where you get the substance. So remember, one is for low is for supra, 0 degree adduction and external is for infra, 90 degree adduction and external is for perifiler, and the peripheral is for the substance. You will say that the substance is also for the substance, the other is also for the substance. But for example, remember the foundation analysis of after that. So slightly don't even have this covered.
Subscap, one more thing. The internal rotation of the humerus is done by subscap. There are more internal rotators. If you neutralize those internal rotators, then what happens? If hand goes back, the other internal rotators like teres major, latissimus, and pec major, all the three are neutralized because there is already some internal rotation. These come straight away in the direction. It comes just directly. Then it becomes adductor. So once you go here, probably you are talking about only subscap. Only subscap.
So then after patient to release the arm like this. So this is the classic case of it, that's what I told you. The two cases you remember from the subscap, one is very great, and the other one is totally, these cases, one is the after patient who can make the and after opposite shoulder,
and press it. Beer hug. Hugging like, oh, when you hug beer. So lift off test. There's a cat. So most of these tests which are done at the extreme level, there is a lag sign. What's the lag? All of you know? ऐसा करो, ऐसा घूम जाओ, हाथ को आगे कर लो, इसको उठा लो पीछे, ऐसे. I can lift his forearm back. Once it is lifted and you leave it, it falls back. If it falls back, it is lag sign positive method. And हाथ में ढकेलो, keep the elbow here and allow him to push your hand back. So you assess the weakness, you assess the strength. Many times, if a fancy examiner is there, वो बोले कैसे पता करेंगे यार ये तो मरीज का हाथ है, सबस्टैप किस साइड का गया है, how can you say? The common answer is सर अपना हाथ लगा के इसको उठाकर देखेंगे. The second is that you can put a BP cuff here, tell him to press by the left and by the right hand. You know which is more strong, which is less strong. So all the four is covered. Now, subcap, you usually get a tear. So signs are good positive. But in infraspinatus, as told by Dr. Samantha, this test, which is also known as horn blower test, in this test is the infraspinatus tendon fatty degeneration which is more common. So here again, ऐसे पीछे करो, and if there is a lag sign. So you see the lag sign and then you see the stress. Why it is called horn blower? शक्ति में देखा है? For the change of your mood, there is a last क्या लिखा हुआ है भाई? Champagne, toast and pour test. It is 5.75 times more authentic for the supraspinatus as compared to your Job, O'Brien, or the Codman sign. If you do in this position, need not be champagne, but you can always do it after the examination. Okay. So we come to the test of instability. Instability has been well dealt with by इतना जान लिया, फेल नहीं कर रहा है, थोड़ा बढ़िया से मुस्कुरा कर बता दिया तो फिर नजदीक है पंजाब है बल्ले बल्ले. Now, whenever there is instability test, ACL, PCL, hip, ankle, please do not forget it. I have brought it specifically. Better score. Please do not forget it. Always check for it, because your instability might be an extension of the global instability present in the patient. I think all of you know it, 9 sports. KT have three at upper limb, one at lower limb, and one is at spine. Spine एक ही होता है, बाकी सब डबल होता है, right? So there are many tests. Let us do एक इसमें क्या बता देंगे? There are two things. If there is a dislocation, you will get an anterior dislocation of shoulder joint. Recurrent हो कुछ भी हो, right? Apprehension test तो करके देख ही लेना है. And when there is apprehension, there is likelihood that there is some subluxation. So press it. Let's go. There is anterior drawer test, there is load and shift test. Many tests are there, but one Job's relocation is a person. You press it and do the same movement of apprehension. Sorry, हमने बोला कि शराब बहुत भारी है.
When you are doing the application, lie down to the always look to the face. It will be equal as zero. Application. Then when you do the same thing, suppose patient is apprehending, and then you just put your palm like this and see the face again, and ask the patient, after analyzing whether he is feeling secure, that means this is not like the joke in the perspective. That means you are giving support to the part, so he is feeling comfortable. Understood? So this is a very apprehension and joke in the perspective.
So whenever there is apprehension, the patient is afraid of getting the joint out. And if the joint is coming out, you give her security and the patient moves. 30, 60, 90 is the standard, gold standard of elbow is shoulder. Most of the tests you have to go 30, 60, 90, 30, 60, 90. And to finish it, we'll talk about scapula. Yesterday, my first lecture was on scapula for 20 minutes, but only thing, wall push-up, मेरा हाथ को ढके लो. To see the winging, maybe medial, maybe lateral, and liquid. You have to tell him to lift his arm, and if there is a problem, again, the same type of relocation test, you have to press it. Shoulder scapular retraction test and a scapular assistance test. So if the retraction is not causing pain, means you are dealing with a scapular dyskinesia. If pressing the scapula on the thorax makes him lift his arm, okay, probably you are dealing with scapular dyskinesia, but the word of wisdom, do not utter this word in front of your examiner. बेटा फंसना नहीं है, it's a tunnel. लिखा हुआ है दर्जले. You should remember एक बार तो यार Biceps is important. Biceps is important. Yeah, right up. But biceps is important. Yes. That's all. And for doing Yargasans, while doing, you should put your fingers on the bicipital tendon, longer bicep. Because, okay, initially, ab initio, it was started for the integrity of the transverse humeral ligament. This is what started. Yes.
So now we'll have lunch break for 45 minutes or like that. And after that, we come back for final examination. Finally, what surgery? By 2:30, try to come there. 2:30, and to get ready with this notebook. Okay, small note, and then each there will be on each there will be 12 questions based on the topic we have discussed till morning. And that will be fine. And the key answer, model answer will also be sent. Model answer. But not now. You put your email, and the marks you obtain will not be displayed. Okay, for yourself.
मैं बोलूँगा सेटअप करना पड़ेगा क्या वाला cannot be identified क्यों Five minutes sure we'll do it
Good afternoon. Now we are going to start the post-lunch sessions. And this is a very happy moment, and see that Professor Dr. Ram Chanda is here on POTS therapy. He will talk on spine, rather he will teach the spine. And it's a great pleasure that Professor S.M. Tuli, he is here with us. He is the teacher of our teachers. And I know this, you read the book, Tuberculosis of the Skeletal System. It is the author, and you see him in front of you. So please, Dr. Chadda, you talk, start your talk.
Good evening, everybody. At the outset, may I share with you that we are talking today about probably the commonest disease which we have faced both in our training days as doctors and after becoming orthopedic surgeons in our practice, outpatient, indoor, and maybe surgical. We are talking about tuberculosis, and we're talking about tuberculosis which is affecting the spine. In life, we basically have 4 sets of people we associate with. We have the role models, people whom you look up to, who inspire you, but whom you cannot physically touch or reach. Then you have mentors. Mentors are those whom you can reach, who handhold you, and you walk you through your journey in life, whichever part they may be a part of. Then you have peers. Peers are the ones whom you associate with on a day-to-day basis, and with whom you spar, you laugh, you cry, you learn, you unlearn. And finally, you have the protégé, somebody who is your creation. The first decision I took today was to step down from that pedestal and stand here, because with us, we have a role model. We have with us a mentor to few. And we are all basically peers and protégés of this gentleman who's the father of tuberculosis in our country. And we should feel both honored and privileged that we have Professor S.M. Tuli here to share this platform. And you should all go home feeling very, very honored and touched by the fact that you were in that same room where Professor S.M. Tuli is. I quote Confucius today. Confucius said, if you are the smartest person in the room, you are in the wrong room. And we are most obliged to you, sir, that you have graced this room to be with us for the next 45 minutes. Thank you so much, sir. I shall try and share with you what I have learned over the past 3 decades in my small journey as an orthopedic spine surgeon, and the mistakes I have made, the newer things I have read about, the older thought processes which were refined with time, and how we modified and made our own small path. Please remember, there is nothing as always and never in orthopedics. What works for a particular patient has to be given to that particular patient, and we should give it with the intent to treat. Hence, we are here talking about POTS paraplegia. I'm not going to speak much about the theoretical part, things which you would get readily from books, but I'll just try and give you an overview of what we are dealing with. The word masquerader describes tuberculosis more than any other word. Please remember, tuberculosis can mimic any medical pathology, and every medical pathology can mimic tuberculosis. Remember that for the rest of your life, that there is nobody besides a histopathologist, and after he has done his work with histopathology, microbiology and all put together, can we believe that what we are treating is tuberculosis? And then today tuberculosis has its variants of primary line or typical tuberculosis, multi-drug resistance, extreme drug resistance, total drug resistance. And we also have these odd things where we're putting these metal implants called non-tuberculous mycobacteria. Just to give you something to go back home and read, we should know all these things. Why do we call that? This is probably lost its importance in the last 1 year. We must look at these figures, which are almost 9 years old now. This was a 2012 global studies where they had 8.8 million new cases in a year worldwide. 1.4 million succumbed to the disease, while 5.7 million were new or recurrent cases under treatment. COVID does not have such large numbers. SARS-CoV-2 is not as numerically bad as this. But this is actually a true epidemic, and numbers still continue to rise. So please beware of this disease. Remember one thing, whenever we feel that we've overcome tuberculosis, it comes out with something new to hit us harder. So we have to evolve with each day. This is what tuberculosis patients looked like, probably in the era which Professor Tuli has treated them, which needed sanatorium treatment as well, and needed a lot of medical management with open air and protein supplementation. But today, very few of our patients would look like this. We would have case scenarios which would be either a complete paraplegia or an incomplete paraparesis with a myelopathy or a thoracolumbar deformity. Please understand, I'm looking at mainly thoracic and thoracolumbar spine because I would not like to confuse the issue of beginning with occipitocervical, going to cervical and also going down to the sacrum. Let's look at what is representative of the disease, most commonly thoracic and thoracolumbar. So you would have a complete paraplegic in bed like this. You could have an incomplete paraparetic with myelopathy, upper motor neuron signs being positive, or you could have somebody who's ambulatory getting a thoracolumbar deformity, either old or relatively new, and if old, may be coming with something called secondary paraparesis or a late onset weakness. So these are three pictures of patients who may come to you as your patient, or probably the person who's going to decide your fate, whether you go across that licensing degree, which a few of us have, and many of you would have soon, called MS, DNB, DORT, FCPS, or whatever it may be. Please understand there are three different words in our journey to knowledge. There is something called expertise, which is a sum of evidence and experience. Evidence you get purely by reading, absorbing, information becoming knowledge, and then knocking off what you think and believe is incorrect. So what stays is wisdom. The other thing which comes with age is called experience. And just like tuberculosis, there are enough masqueraders who may masquerade about the experience. But please remember that as you grow older and see more patients, and your own patients would teach you, we have to give weightage to not just evidence, but also experience. Another very interesting thing about paraplegia, tuberculosis of the spine, Everything else in orthopedics has two components, which is biology and mechanics. Am I correct? In tuberculosis of the spine, there is a third major component called neurology. And this is that twist, that chasm that we have to cross to achieve a good result. Because everything boils down to how you manage the biology and the mechanics, which prevents worsening or reverses the neurology. So what is biology? It's either the disc or the end plate getting affected primarily. What is mechanics? A collapse and a loss of the structure, mainly in the sagittal, but could also be in the coronal plane. And that one separate issue of a neural structure getting compressed is the neurology. So this is the only pathology where all three variables need to be looked at and very critically. Hence, we shall go through step by step of how you would assess and evaluate a tuberculous spine, which we are looking at as a bigger picture as what is paraplegia. In history, if any one of you could get up and tell me what are the 5 salient questions you will ask in a patient, any one of those 3 pictures that I showed you. Any young man would like to get up and fathom a guess? Any 5 points that you would look for or ask a patient which are relevant to spinal tuberculosis with a weakness? Any 5, yeah. Bowel or bladder involvement. So you're looking at a neurology where there's a cauda equina component or a myelopathy coming in, which is significant. Very good. Previous treatment taken, if any, and outcome. Very nice. How long is the disease process? Very nice. Any tuberculous contact? Very nice. Any weakness, difficulty in your clumsiness of gait? Very good. Sit down. Anybody else? Anything that comes to your mind that you would like to ask? ये हर TB के patient में पूछना चाहिए. What are these constitutional symptoms of signs? Loss of weight, loss of appetite, evening rise of temperature. These are things that you need to look at. Tell me one question you will ask a patient if you want to know whether this person is taking anti-TB medicine. What urine color? Does only the urine get discolored or something else also gets discolored? Come again? Besides urine, all sweat gets discolored? Which of the medicines causes discoloration? Any other medicines outside TB that you know of that can cause the same discoloration? Anti-TB medication? Come and complain of pain, whether it is bearable or unbearable, whether it happens more at night, whether it is along the vertebral axial column, or whether it is radicular. What is radicular? We know of radicular going down the limbs, upper and lower limbs. But if it goes along the costal margins also, in the intercostal space, that is also a type of a radicular symptom. Next, the constitutional part. Loss of weight, appetite, evening rise of temperature, fatigability and lassitude, lethargy. Patient is not feeling good. Neurological, perfect. Imbalance of gait, sphincter challenge, very good things you said. Any incontinence, any overflow? Has a catheter been put in by anybody? Using diapers? Important questions. Past history, close contact, any pleurisy. Many of them will not tell you they had TB. They will say they had pleurisy in the past. Any lymph node biopsy done at any stage? Any long-term medication that they took for 6 to 9 months? These are questions that you need to ask patients. Is it causing any orangish discoloration of urine or sweat? Have they taken medicines which were given across the counter, or did the doctor change the dose of the medicines as they lost or put on body weight? Have they taken the medicines for a few months, had orange discoloration of urine, and stopped taking it completely thereafter because they felt better? Why are these important? In today's scenario, the commonest cause of MDR tuberculosis is incomplete or defaulted treatment in the past. And we should look for such defaulters because these are patients whom we have to then keep a critical eye open for these being not typical, not responding to primary line, may need secondary line of treatment. Is there any immune depression in the patient, any other comorbidity, any malignancy? Is there any morning stiffness associated with this? Is there any visible deformity? Why do I ask for morning stiffness? Do you know that sacroiliitis, if it is one-sided, is more likely to be, is more likely to be tuberculosis. If it is bilateral, it is more likely to be ankylosing spondylitis. So just keep these small things at the back of your mind. Any surgery is done. Even, sir, I had a small swelling here and there was an incision and drainage done. Look for that. Ask them for it. Any biopsy, menstrual history. A lot of ladies have genital tuberculosis and their menstrual history gets altered. What is this RPS? Now, this RPS is rifampicin, pyridium, and senna. These are 3 sets of drugs, all of which can cause orangish discoloration of urine and sweat. So remember that these are 3 medicines, all of which can cause similar discoloration. Please ask them for the same. Now let's go to examination. This is mota history part. When you are examining any one of those 3 patients whose picture I showed you, how would you examine? Anybody gets up and tells me 5 points. 5 points in the examination. If a patient is lying in bed and is barely moving his or her toes, is in a lot of pain, would you examine the gait of that patient? You will inform the examiner that I have intentionally avoided examining the gait of this patient because the patient is insane. You are entitled to say that. And it will be taken as a positive remark and not a negative remark because your duty is to look after the patient. However, if you have somebody with a deformity, but who is ambulatory and walking all around and you do the same, you are incorrect or wrong. So in examination, what do we look for? Is he ambulatory or non-ambulatory? Is there tolerable pain or intolerable pain? If not ambulatory, is there lack of ambulation because of pain alone or because of pain with neurology? Keep this at the back of your mind. So you have to look whether there is disabling pain. Is it challenging the gait? Are movements of the spine painful? And is there a worsening of neurology when the patient is made to work against gravity? There are some patients who, while lying down, will be able to lift up their lower limbs anti-gravity. The moment you make them stand, they will buckle. I just said something. When can that happen? A patient lying down is able to lift up their lower limbs. The moment he or she stands up or you make them stand, they buckle. Beg your pardon? When can that happen? Postural hypotension, fine, agreed, but they genuinely neurologically buckle. Is there any patient who can have a neurology which is less or compensated in the lying down position, and when they sit or stand, the neurology worsens due to something happening? Any idea? It's more common, now I'm giving you another, it's more common in the elderly osteoporotic fractures with incomplete neurology, where we do sitting and standing or sitting and supine lateral x-rays of the spine. There are people who have early thoracic myelopathy or at the cauda conus level who may get a weakness whenever they are vertical, but in the supine position, there is no significant neural compression, and the patient even has an anti-gravity SLR, straight leg raising. Always explain. This is a very important point. Whenever you want to do any test on any patient, you have to explain to the patient and take or seek permission. Am I clear about that? You ideally should also seek a chaperone if you're examining somebody of the opposite sex. Am I again clear about what I'm saying? If you're examining somebody of the opposite sex, as far as we are concerned in our country, you need to seek a chaperone and you have to seek permission of that patient before you examine or please remember that. Explain, counsel, and seek consent for each test done. Special permission for skin marking or if you believe the test may be painful. Let's look at inspection. We all go by the standard inspection, palpation, percussion, auscultation, which we learned. We may not extrapolate all to fine, but we always begin with inspection. What do we see from the front, back, and the side? If you see here, these are various areas where you may have to look for swellings. Where is this swelling? If you have a swelling here, where could that swelling be tracking from? Come again. There's a French name or a French translation of the word small. Thank you very much. So you could be having something coming from the petite triangle. Am I correct? So that's something there. What is this? That's the rib cage and you can see something there. So you can at times have a swelling where there's a tracking along the intercostals. Centralization of the head over the torso and the pelvis. Look at the patient from behind, look at the patient from side. See if there's any visible spasm if the patient is in pain. Is spasm good or bad? Is spasm good or bad? Beg your pardon? It's a protective mechanism. So is it good or bad? It is protecting the patient. Although it is giving pain, it is protecting the patient. So if a person comes to you with a severe muscle spasm, would you give him a painkiller or would you give him a muscle relaxant? You'll give a muscle relaxant so it doesn't get the protection and the primary disease gets worsened. Okay. So just remember, you have to look at it as a balance. Where it is a protective mechanism, let the spasm there, but reduce the cause, which is the pain. Purely giving a muscle relaxant may add insult to injury. Just remember that. Okay. So centralization of the torso, shoulders should be balanced. When you're looking from the front, the nipples should be at the same level. Your area of vision through both the arms and along the side of the body should be identical. Why do we say all this? Skin folds is that we are looking for a coronal imbalance. If there's a coronal imbalance, any or all of these may be altered. Shoulder balance, scapulae, everything gets altered. Look for swelling, scars, sinuses in the neck, intercostal region, iliolumbar, inguinal, femoral, paraspinal, petite triangle, and sacroiliac joints. These are all the places where you can have abscesses checking down. Am I clear? We also look for trophic changes, especially in that first set of patients, which I showed you of the first, second, and third. So first and second. Gluteal regions, sacral regions, trochanters, and heels. Why do we look for trophic changes or ulcers? Because there is a sensory involvement, it will tell us the chronicity of the pathology. Am I clear? So if you have trophic changes, this patient has had this neurology with sensory deficit for a much longer period of time than what probably you may be suspecting. What is Beaver's sign? Has anybody heard of Beaver's sign? And why the hell have I put it in inspection? Well, this is an odd sign, but it's worth using if you really have something which is in the lower thoracic or thoracolumbar junction. When a patient is told to flex their neck anti-gravity, there is an eccentric pull of the umbilicus on one side if there is a compressive pathology around the D10 level. Why do I put it? Because there are some examiners who are very fond of asking, tell us that one sign that you can do in tuberculosis where you don't need to touch the patient. Here you don't need to touch the patient. Patient is supine. He or she is told to flex their neck anti-gravity. And if there's eccentric pull of the umbilicus, that means one-sided the abdominals are weaker, the other sided they are still contracting. There may be a disease, an SOL, a compressive pathology around D10 vertebra. Always look at the sagittal plane, cervical lordosis, thoracic kyphosis, lumbar lordosis, and look for these three words. Again, examiners very fond. What is a knuckle? What is a gibbus? What is a kyphos or a kyphosis? And is there any kyphoscoliosis? These are words which all represent a kyphosis. Okay? But read exactly what a knuckle is, what a gibbus is, and what a kyphus is. A knuckle is the smallest. A kyphus is more than one set of vertebrae, 2 to 3. And a complete, that's a gibbus, and a complete kyphosis along the entire thoracic spine. And a kyphoscoliosis is a deformity both in the sagittal and the coronal planes, combined three-dimensional deformity. Confirm that the respiration is the normal abdominothoracic, symmetric or asymmetric. Why do we see the asymmetricity or symmetricity of the ventilation? And how do you see it? What do you look for? All this is inspection. Take a deep breath. What will you look for? Come again? Anybody? This is, we are all learning from each other. I am learning from you. If there is eccentricity, that means there is an eccentric neurological cause. One side may be more affected than the other. Also, which level of thoracic sort of intercostals are working and which is not will give you a guesstimate of where are you looking at for the lesion in the spine. These are small things but can be done. In a long case, you have a very long time to spend with the patient. Go ahead and look for all these things. Next, coming to palpation. Please remember that your hands have to be warm. They cannot be cold, they cannot be wet. And nowadays, they have to be sanitized before you touch the patient. Okay? You have to use the front and the rear of the hand. Where do you use the rear of the hand? For temperature. Very good. How do we check on the spine where we are? And are you people very fond of writing on the spine? Next question I'm asking. With humble request to each one of you, don't commit to a level on the spine. You can always use words, but don't commit. Even on an MRI, there is sometimes a dispute whether you're dealing with L5S1 or L45. Just go by what you feel. This is, for me, sir, the C7 vertebrae, because I feel it is vertebra prominence and it is just above the longest spinous process. T1 is actually the longest spinous process. So C7 is the one just above that. And it's called vertebra prominence. So that's what you can say. These are all things which we use in the pre-CT, pre-MRI sort of an era. And even because the X-rays at that time were not very clear to see at the cervicothoracic junction. But today, we still have to know what is where. Spine of the scapula is at D3. Inferior angle of the scapula is at D7. Iliac crest is usually at L4 spinous process. Sacral dimple or dimple of Venus is usually at the S2. It may vary up and down if the patient has any transition vertebrae. Am I clear? The knuckle is an abrupt beak. The gibbus is a prominent hill, while the kyphus is a gentle hillock. Am I clear? So don't commit anything beyond that. Knuckle is an abrupt peak. Gibbus is a prominent hill, while a kyphus is a gentle hillock. Remember it that way. Temperature is with the dorsum of the hand, especially if there's a visible swelling. How hot or warm is a tubercular swelling? It is not as warm as a pyogenic, correct? That is why it is called a, thank you very much. So we should always feel that. And when we are talking of the rear, always remember, I mentioned all those points, right from here, to here, to here, to petit triangle, to inguinal region, to femoral, psoas, iliopsoas. Look for the psoas axis and find it. In the earlier days, when we were in our training days, when we had small children with flexion deformities, these were the ones used to have pyogenic psoas abscesses. And tubercular psoas abscesses used to normally not have these acute symptoms. Today, we hardly see those pyogenic psoas abscesses. Most psoas abscesses turn out to be tubercular. For whatever reasons, I'm just trying to share where I am today. Whenever you are examining a patient and when you're asking for pain, the face of the patient should be seen by you. Am I clear about what I'm saying? Even if he or she is lying prone, you have to request the patient to turn to the left because you are standing here to the right of the patient, correct? And you should see. Why should you see the pain, the face for the pain? It's the wincing on the face and not what she exclaims from her lips, which actually tell you the amount of pain that they have. And you cannot go beyond that painful level. Please remember that. You have to respect that pain threshold of the patient. What is tenderness and how do you elicit it? You have to look for all the posterior elements superficially and deeply by moving them. You can do it in different ways. Some people will use their thumb, some will gently tap with this, some will try to move it from side to side. But don't do anything too painful. It doesn't really add to your clinical judgment because you are going to follow it up with radiology. So do it gently and identify, avoid the pain. Always do a sacroiliac stress test bilaterally. What did I tell you earlier? Unilateral pathologies can be infective, while bilateral can be inflammatory. Am I correct? Next, we go to movements and certain special tests. What's the difference between movements in an infective or neoplastic pathology versus a degenerative pathology? All infective or neoplastic pathologies will have painful restriction in the active acute phase in all arcs of motion. Do I repeat what I'm saying? All arcs of motion will be painful. While in degenerative, like a disc, there will be one arc which will be painful or half an arc which will be painful while the other arc may be painless or maybe even relieving the pain. So degeneratives can be differentiated from infective versus neoplastic. Check all the movements of the entire skeleton, flexion, extension, rotations, and lateral bending. Two tests which are not specific for TB, but remember them to differentiate from tuberculosis is the lumbosacral movement test called the Sober's test and the modified Sober's test to see the excursion of the lumbar spine and lumbosacral spine. Chest expansion, again for ankylosing spondylitis, and tragus wall distance. All these are mainly to differentiate angstpon from TB. Keep that at the back of your mind. What are the recommended levels that you need to know? Sober's and modified Sober's mobility normally should be more than 5 centimeters. Chest expansion at GP sternum or at the mammary level should be more than 5 centimeters. And the tragus to wall distance should be less than 10 centimeters. Just remember these as thumb rules. Keep all these things with you in the examination tray. Carry them in your apron when you go. Cotton wool, pin, divider, tuning fork, hot and cold water test tubes if available, knee hammer, tape measure, goniometer, and a plumb line. Am I clear? All this goes with you in your kit. This is your tool kit. It's a new word which you're hearing nowadays, right? So this should be a part of your tool kit. How do we look for neurology? These are dermatomal marks and myotomal marks that have to be impregnated in your hard disk up there, and you have to follow it every time in the lower limbs and in the upper limbs. Here it will be mainly lower limbs and the chest because you're looking at thoracolumbar. What all do we look for? We do all these tests on the patient, checking their neurology. Higher functions basically have to be ruled out first. Most of our patients in the examination will be with normal higher function, but there will be certain elderly patients whom we need to respect. So don't call them anything like organic brain syndrome. They are not, they are just old. Okay, so just don't use any words outside our text, please. Next, we also check, as I said, like the beaver, you have to check for the isometricity of both the recti muscle on either side of the umbilicus. Check all the motor power. There is an MRC grading. We should know what is MRC grading and what is 0 and what is 5 and what is 0 by 5. You can't say the patient's power is 3. It is 3 by 5 MRC. The statement has to be complete in the examination. Don't wait for the examiner to ask you what is 3 by 5. Finish it in one straight line. No questions after that. Sensory, superficial and deep, pressure, temperature, pinching, pinprick, hair lift, all these have to be done. Where do we do a hair lift? Why do we hurt patients? Do we do a hair lift anytime? When will you do a hair lift? I've written hair lift, you agreed. Why do we do hair lift? You will do a hair lift when you're looking at the recovery phase of a patient. A patient who has gone beyond this stage and is coming back, those are the areas where probably in the recovery phase, where he's negative to everything else, he may first probably get a hair lift positive even before a pinprick. So these are things which you should know. Positioning. How do you check the sense of position? You all have done all the tests. This is for the upper limb, but lower limb is toe to heel test on bilateral side. All these have to be done. Why? Where are these columns coming from? Where are these pressure, joint and sense of position? Where are these columns in the cross section of the? These are posterior columns. Perfect. So this needs to be checked. Where in tuberculosis does the posterior column alone get affected? Which part of tuberculosis? Which disease is it? Which aspect structurally? TB is only an anterior disease. So when does it happen? Somebody said posterior, no? What is only posterior element tuberculosis called? Come again? Come again? No. What is spinal tumor syndrome? There is an entity described, right? But predominantly it's a posterior disease. Okay, you need to know that. For that you need to read Sir's book. Okay, and I'm talking of the first edition. Sir has released the third edition है आपका sir, fourth edition. Which is the edition now? Which is the present edition is the third one, sixth one. I'm talking of the ones that we have read. Everything. Yes. Okay. Next, you have to see the coordination. That's the heel chin test. Finally, you have to always look within the limits of your deep tendon reflexes. How are deep tendon reflexes classified? They are brisk, exaggerated. That is on that side. Then there's a normal, diminished, and not elicitable. Just like 5 MRC grades, these are the grades. Normal, slightly more than normal, is exaggerated, and beyond that is brisk. This side is diminished and not elicitable. You have to do it for upper limbs and lower limbs. What is the Gendrastic maneuver? What do you do? Yes, what does this do? Exactly. So what are the other things that you can do besides this? Clenching. What else? Number counting. What else? Thinking about good things. What else? So you can do all these things so that you can distract the patient, get talking to the patient, probably get them to do this, right? Besides this, you also have to look for the other things more so in an acute picture, an acute onset presentation, the bulbocavernosis, where you put in a per rectal digit, or give a glans pressure, or do a catheter tug, especially in the ladies. Anal wink, turn the patient around, sensation. Ask the patient if it's been there for some time, they will tell you. Plantar reflex. We all know how to do the plantar reflex, but we should know how to elicit it without using the knee hammer. How do you elicit a plantar reflex without using the knee hammer? Anybody? Yeah, you're saying you're right. You put pressure on along the shin of the tibia. If you roll it down and do it aggressively, you may get a plantar reflex. Not always. It's still the best to go with the knee hammer, but you should know that there are other ways of doing it. Having said that, There are entities called clonus. What is clonus? There's patellar and ankle clonus. It's passive pressure with the thumb and the index finger on the superior pole of the patella, going downwards to the tibial tubercle, which will cause a jerky reaction. Ankle, support the, I'll show it to you, and then you get a flapping of the ankle. What is ill-sustained clonus and what is well-sustained clonus? If the involuntary flapping is more than 30 seconds, it's called well-sustained. Otherwise, anything less than half a minute is ill-sustained clonus. Usually, patients will have ill-sustained clonus to begin with, which will then become well-sustained over a period of time, or if there's a very large compressive pathology. What is Hoffman's sign in the upper limb? And how is it done and what is it done for? This is for the cervical myelopathy. Do you check it always? Yes, you always need to check it. You may have tandem pathologies in tuberculosis and degeneration where you have to look for upper limb as well. Having got this, you'll have a sensory and a motor level that you've established. These are the tests. That's how the knee jerk will come. So you have normal, exaggerated brisk, normal, diminished, absent. Am I correct? I don't use the word absent. I use the word not elicitable. By taking the word from absent to non-elicitable, the non-performance of the test is taken on our shoulders rather than that of the patient. So use that word not elicitable. It's a big shame if you can't elicit, but your examiner comes and does it if you've called it absent. But if you called it not elicitable and he does it, well, it's a matter of learning. We all learn. So use these words very, very carefully. So that's the knee jerk. What's that? That's your ankle clonus. Am I correct? Anything less than half a minute, ill-sustained. More than half a minute, well-sustained. What's that? In this position, Hoffman. What happens in Hoffman? An involuntary. What do? You stabilize the DIP of the middle finger and you then slap it downwards while the index and the thumb will do this. Correct? Check bilaterally. We have various classifications in the country for tuberculosis and other parts of the world, from Seddon, Kumar, and a lot of it. Today, we are not going to go more into the details of the classification. Let's jump to management because that's what's going to be asked to you. Anything in life, you have at least two choices. Correct? There's a fourth. There may be more than a second choice, which may be the right choice, but we look at two choices to begin with. Unfortunately, as spine surgeons, we only see the mechanics and the neurology and very rarely realize the efficacy of non-invasive medical management for the biology. Please remember, tuberculosis is a medical disease. Large number of patients in the worst case scenario will respond to tuberculosis if both the patient and the surgeon are patient enough. Please remember that. What are the questions to be answered? Is it now a writing on the wall? Can we treat TB as an isolated identity only as a spinal orthopedic problem? Or do we need to be more proactive, more aggressive, and more attentive? What all do we do? We need to do X-rays, AP and lateral views, if necessary. Also do an MRI, preferably on a 3 Tesla. 1.5 Tesla is also very good for the spine. We may need to add CT scan, and there's now a lot of study going on with PET CT. A few people are talking of healing of tuberculosis more evident on PET CT. Just keep that at the back of your mind. These are what X-rays will look like. This is also a discitis without collapse. This is a discitis with collapse. Always have a complete picture of this transection of the spinal cross-section of the spinal cord to know what you're dealing with. It will tell you mentally where your pathology is. Is it affecting the anterior part of the C-curve or the cord or the posterior part or circumferential? This is not a very common finding today because hardly people do good quality X-rays or patients present much earlier. But this was what was the bird nest picture that we have in books. But this will still be found in a lot of patients where you will see this shadow on a plain film. Do not ever miss this. I still insist on plain films in all my patients, and I would request you to ask for plain films, even if the patient is in the exam and doesn't have one, ask for them. What do we do most of the times? We do MRIs. Why is this MRI shown? This MRI is shown just to tell you that there's a large number of skip lesions in tuberculosis. And don't concentrate only on one. There may be multiple lesions even above and below that, and even in the rest of the skeleton. Abscesses and granulomas are a part of the pathology. They can be all over. There is a spondylodiscitis called the classic lesion, osteitis or central body lesions, paradiscal lesions where the disc is to a certain extent spared. These are all the types of things. And of course, there's a posterior element TB, which is atypical, or an intraspinal TB, which is within the theca itself. That we don't directly, aggressively do much with from our side. We take medical help for the same. These are what abscesses would look like. These are what granulomas would look like. These are what they are, wherever they are, paraspinal, prevertebral, epidural, all these are various pictures that you need to identify and look for. Spondylodiscitis may be limited to one vertebrae. There may be now a progression to contiguous vertebrae above and below, and there may be a spread above and below. These are all tuberculous lesions. Osteitis is where the bone is getting involved. As I said, these are masqueraders. What I'm showing you here are all TBs. But then these could all be non-TB, purely on imaging. Hence the need for a histopathological or a microbiological confirmation of the same. Vertebra plana, very common in tuberculosis. As Sir mentioned in his oration this morning, earlier it used to be called only eosinophilic granulomas, but it can be anything from multiple myeloma to MET to eosinophil granuloma to even a tumor like an ADC or a GCT. Paradiscal lesions, which are more pre-vertebral or within the canal, paravertebral. Atypical single vertebral disease, concentric collapses, ivory vertebrae. There are various types of these lesions which are seen. Neural arch getting involved, circumferential, multiple vertebrae, incontinuity, and skip lesions. These are all posterior element and atypical presentations. Spinal tumor syndrome, where there's just the posterior element involvement, which is rare and which needs to be looked for. Multiple vertebrae getting involved, very, very common. Now, especially in the MDR picture. Remember that? Also, a very high pickup rate because of MRIs. Another thing, a picture like this at times can even mimic psoriatic arthropathy. Just remember these odd things, stupid things at the back of your mind. Sometimes you rarely see something with a psoriatic arthropathy will have an MRI picture like this. There are sometimes changes in parathormone levels which may mimic pictures like this. Just keep these at the back of your mind, but rarely. Not as a rule, they are tuberculosis. Who manages this whole show? You have yourself, which is the spine surgery team, but sitting over you, you need a good radiologist, good pulmonologist, and a good microbiologist. This is an extrapulmonary paucibacillary disease. Please remember that. Treatment is anti-TB, rest and bracing. This is the biggest majority of patients are treated with this. Chemotherapy, primary AKT, secondary AKT principles is what we are going to look at. This is more from the sake of completion, but you should know them. Today, what is accepted as the line of treatment, and there are different schools of thought. I'm quoting one. You may have a representation which is slightly different. I respect it. Intensive phase is 2 months of HRZ plus E or S. A lot of us don't use S, which is streptomycin. Continuation phase is 4 months of HR, 2 drugs. And the dosage, as I said, HR, EZ, 5, 10, 15, 15 for streptomycin, and Z is 25. So just remember, this is milligram per kilogram body weight. All drugs have to be given as weight per volume. Please do not use those multi-drug sort of packets which are available, AKT4 and all those. Those don't work because most of our patients keep changing in their body weight. That is meant for a 50 kg patient. So most of our patients don't come there and they're usually lower medicated than they ought to be. Duration of ATT, again, there is a lot of debate. There is no sort of jury is not yet out. People will be using it for various periods of time. I respect anybody. This is commonest being used today for about a year. 2 months of RHZE and 10 months of RHE. This is coming from people who are studying it on a regular basis. Close monitoring or development of neurological deficit has to be kept in mind. As I said, whether it's 6 months, 9 months, 12 months, or 18 months, or till disease heals, jury is not out. We are still waiting. There are people coming out with papers of only 6 months, and there are people who insist that I don't stop before 18 months. So we have both ends of the spectrum. Next, secondary line. Now, these are all very, very, what would I say, difficult medicines to handle by us. It's always better to have a chest physician or a tuberculosis specialist, especially in using secondary line of drugs, because these have more side effects. They have to be given for a longer period of time. And please remember the basics. When you are starting secondary line of drugs, you are not stopping the primary line. The primary line is continuing. The secondary line is being added in addition. तो प्लीज रिमेंबर, अपना तो हम हैंडल नहीं कर सकते थे, तो लिवर के साइड इफेक्ट्स और स्किन का होता था और डेफनेस और विजुअल होता था, उसके ऊपर दिस इज मच मोर. So please do not essay or don't be too valiant or too brave or courageous to handle these by ourselves, but we should know what we are dealing with. There are various medicines which go from kanamycin to quinolones, all the way down to ethionamide, cycloserine, and these are all very strong chemotherapeutic agents. There is PAS powder which is used, clofazimine, and multiple drugs, and they are added in a large number. That means besides the 4 that you're giving, they may add directly 3 to 4 drugs and then add it for even up to 24 months. So these have to be looked at very, very critically. These are side effects of these drugs only presented for you to know. We need not know them by heart, but we should know that they affect a lot of our systems which we can't handle. How do you diagnose this MDR COX? Well, you should suspect every patient who's not going along smoothly to have MDR COX and is not improving or worsening on 3 months of treatment. There are various things, like I'm showing you here, there are people working on PET, CT, etc. to look at healing. Similarly, they're also looking at irregular drug intake or looking at non-improvement or incorrect regime or low volume treatment being given. They also are looking at known contact with MDR, whether you are being exposed to somebody with MDR. So all this has to be looked at. Whenever you suspect MDR, send the specimen for an AFB culture. Patient should be started on at least 2, ideally 3 new anti-TB drugs before or while doing the sensitivity test as before they arrive. Once the results arrive, final regime is at least 4 sensitive drugs. So that's what I'm telling you. They have your original 4 drugs. They will add 2 or 3 and then add a 4th one to it. How do you manage these patients? Drugs are continued for 18 to 24 months. Monitor them for all these adverse effects. Drug reactions are more common. And we must remember that today there are 2 new drugs which are available, which supposedly are working wonders for XDR and TDR, besides MDR, which are delanamide and bedaquinolone. These are 2 drugs which are now available in India and have been permitted for use for our patients. It is a notifiable disease. Use a chest physician or TB specialist to get these drugs for your patients. These drugs are working wonders in patients who otherwise were suffering a lot. And today we have evidence that there is better TB. WHO estimates that there are nearly 500,000 new cases of MDR per year. And for this, these 2 new drugs are now available. What's the new hope? Well, they are bedaquiline and delanamide. They offer hope for more effective, less toxic MDR treatment. Historical standard of care and some newer regimes, certain subgroups of patients, including those with HIV or Hep C or diabetes, with worse treatment outcomes, are getting better results with these 2 new drugs. So keep that at the back of your mind. You should be aware of the same. Now we come to the part that we handle. So the majority of TB is over. We at times rarely may need to intervene in tuberculosis of the spine. How do we do that? Well, we also continue the medical line of treatment, which is medicines, resting, and bracing, the way you wish to use it. What then are the indications of this disease surgical management? Please remember, it's a team approach. It's not a one-man's job. The entire pulmonologist, radiologist, microbiologist, you, and the entire group have to work together. Physiotherapy is an integral part of the treatment. We have to have a team approach. One thing is a ritual before every surgery that we do today. And I swear and stand by it that we do it every time. That is a good diagnostic biopsy or tissue. Without tissue, we do not move ahead. We may repeat the need for tissue even at the end of 1 week or 10 days if the first one is inconclusive. Are you clear about what I'm saying? You do a biopsy, it takes 5 to 7 days, but you may have an inconclusive. counsel the patient in advance that I might need to do a repeat biopsy. Either I or my CT specialist, whoever is doing it, will need to do it. Benefits of a biopsy far outweigh the possible complications associated with the procedure. This is what my biopsy recommendation or form is there, which I send with my patient. And I study everything. I do histopath, I do gram staining, aerobic, anaerobic, backtec flux, extended intubation, Zeal-Nielsen staining, linear probe assay, LPA, smear positive, MG, TB culture, drug sensitivity, gene expert, fungal smear, and others like brucellosis at times. So remember that any or all of these may be necessary. This is the way we go ahead. How is the biopsy done? This is what a CT guy would do. This is what they would repeat it. I mean, this is what the gene expert would show, whether it is detected, whether it is low or high, and whether any resistance is detected. So this is a typical tuberculosis. Is that clear? This is what your report would look like. Well, at the end of it all, then why the hell do we ever have to operate? Well, we have to operate certain patients. These are patients who are developing neurology or despite medical management are worsening in pain, worsening in neurology or constitutional symptoms or developing a deformity. What do we do for these patients? One set of patients are those in whom their diagnosis is not clear, which is the type 1. These are single level discitis or they are forming an abscess. These can be treated by minimally invasion, get that culture out, get the material out, study it, and then send it for sort of whatever testing you want. Don't do a major surgery. Type 2 is where there's a collapse, but the collapse is still less than about 20 degrees of Cobb. This can be addressed either anteriorly, posteriorly, isolated manner, whichever way you want, decompress with or without stabilization, ideally stabilize them with or without instrumentation. Again, your call. Today's generation is instrumenting all. So just remember that. And finally, there's a severe deformity, severe collapse, neurology, which needs the decompression and stabilization. There was a stage when we were doing back and front surgeries. Now we moved to doing all back surgeries, which means doing the front surgery also from behind. Debridement and clearance of the granulation tissue. Does it really help facilitation or penetration of the anti-TB medication at the site? I do not yet find any evidence, but there are people who still believe in it. And if it does, great. If it's a feeling of well-being and the total disease is being reduced and the AKT can work better, sure, go ahead, make it a part of the procedure. But there is no true level 1 evidence available as yet. There may be times that there is some facilitation of drug transfer or transport to the diseased tissue, but it's not yet available. This was Sear's findings in 1989. So when do we operate? Neurological deficits with an acute or a non-acute onset caused by compression of spinal cord. Unlike fractured spine, spine, even if presenting late with a neurology, has much better chances of recovery. So please remember, tuberculosis of the spine, even if presenting late with a neurology and you're planning surgery, has a better prognosis than a fractured spine presenting late. So give it that chance. TB spine was a slowly progressing disease. Fractured spine was a direct one-day insult. So just remember that and keep it at the back of your mind. Spinal instability caused by destruction or collapse of the vertebrae. Destruction of 2 or more vertebrae or collapse or kyphosis more than 20 degrees is a clean-cut need. No response to chemotherapy is another need. Maybe we are treating the wrong disease. Non-diagnostic biopsy more than once is an indication. Large collateral damage by the abscesses. Suppose there is dysphagia, dyspnea, something because of a huge abscess, or there is a huge psoas causing some neurological problems, superficial femoral nerve or something of that sort, lumbosacral plexus getting infiltrated. Those are collateral damage, relative indications for a surgery. In thoracolumbar tuberculosis, what do we do? Well, what are the criteria? The first paper which came out from Mumbai was by Dr. Jwalant Mehta and Shekhar Bojraj, and they tried to just look at various forms of presentations, group A, B, C, and D. D was the posterior one that I spoke of, where only a posterior decompression is taking care of it. A is where the anterior lesions are stable with no deformity, can be treated only with an anterior surgery. B was global lesions, needed posterior and anterior according to them then. And C were global lesions but had an high risk for anterior surgery, so they did everything for posterior, called the transpedicular approach. Now, most of these are also done this way. That's where I'm coming from. Earlier, there was A, B, C, and D, which were separate, but today, the B and C are actually in one basket, and most surgeries are done from behind by a large group of patients. There are a few people like me who still enjoy doing a surgery from the front, and I also do it thoracoscopically, but I am an exception and not the rule. And innovation came, and it came from across the border, from the part where my father moved into this country before partition, and hence many people don't respect it. But I have huge respect for this presentation which came from Pakistan. It's about thoracolumbar tuberculosis, and it's a way of trying to predict what will benefit with surgery and what may not benefit with surgery. They've actually gone very systematically, given scores on history, given scores on examination, found a location coefficient D1 to D10 being 2, it's a multiplication factor, D11, D12, L1 junction being 1.5 and lumbar disease being the least. And they've given a score which you achieve, which is easy to use, where you get points from clinical history, points from examination. There's a location coefficient, so it's A, which is history points, and clinical examination score multiplied by where it came from, thoracic, thoracolumbar, or lumbar, and you get a score. That score, if it's less or equal to 5, it's non-surgical. If it's more than or equal to 8, it's TB medication plus surgery, and 6, 7 is a gray zone, institution specific, patient specific, surgeon specific. So you could have a wide window in between, but it is useful in taking certain decisions. Why do we do that? Because in this disease, it's a big war between the out of focus patient who's unhappy and the poor surgeon who's struggling to find an answer, and the family is really, really perked and disturbed about the whole thing. So the only person in focus is the caregiver or the attendant. Another small point, fear that tuberculosis forms a large biofilm on stainless steel or titanium implants should not be used there. Well, you can use them safely. There's no real issue with the biofilm that is being formed on the titanium alloy anymore. What are the types of surgeries that we can do? You can do a purely anterior thoracic surgery, which I used to do at one time. I used to love doing them, going transthoracic, you go to a transpleural, go in, remove, decompress completely, use one of those ribs, morselize within that mesh cage, put it down and put a dual rod from the front. Or you could do all posterior, which could be a long posterior construct with decompression stabilization in situ, respecting the anterior pathology. Or you could do a front and back like this, where I have to open from behind, put the implants, and do a thoracotomy from the front and go in and put that mesh cage. And now what we tend to do most of the times is do the front also from the back, which is go lateral and push that cage in front with morselized graft. Yet another option, which I did for the first time and on my own sister-in-law. This is my wife's younger sister, whom I operated about 12 years back. And there we did a sort of decompression with stabilization with a posterior shortening procedure. She was MDR top, one of the first that I treated. And she did reasonably well. And this is what we started doing thereafter, which is you reduce the anterior void by doing a posterior shortening procedure. This looked like a tumor on CT, and I was really sort of just a difficult decision to take, but we went through it and I learned a lot from this patient. Having said that, is there evidence? Well, there is a lot of evidence about everything that we say. You just go into literature and look for it. A lot of this evidence comes from India and from the Asian subcontinent. So go and read it. The only thing which I would say is, though the anterior approach is favored method for debridement and decompression, as the lesion is situated anteriorly, there is increased morbidity related to the transpleural approach. The posterior or posterolateral approach gives reasonable access to the lateral and anterior aspects of the cord for an equally good decompression. Better functional outcome and significantly better sagittal plane and kyphosis correction by posterior approach are strong pointers favoring the approach. So we have now gone the complete circle, where we started from posterior, went anterior, stuck with anterior, did minimally invasive, have come back to posterior via an anterior and posterior approach. Finally, the last two slides, what are the indications for surgery? Without neurology, if there's progressive bony destruction despite the medication, failure to respond to conservative therapy, increased abscesses despite the AKT causing collateral damage, uncertainty of diagnosis, mechanical instability due to destruction or collapse of more than 2 vertebrae with kyphosis, more than 20 degrees, prevention of severe kyphosis in young children with extensive dorsal lesions. By choice, I've kept the childhood tuberculosis out of today's presentation. That's another 15 to 20 minutes and is a huge different subject by itself. Please go back, read all about it, and read about the criteria which determine the instability in the child. Large paraspinal abscesses causing collateral damage. With neurology, well, most of them will need surgery. New or worsening neurology under your eyes, lack of improvement in conservative care, paraplegia of rapid onset, late onset paraplegia, neural arch disease, painful paraplegia in the elderly, spinal tumor syndrome, epidural tuberculoma without osseous involvement. All these need surgery. Having said that, does surgery for tuberculosis actually eradicate the disease? Please remember, tuberculosis never really heals, it becomes quiescent. All of us have quiescent tuberculosis within us. It may wake up someday when we are low immunity wise. Remember that if somebody says, is this disease healed? You can say, sir, it appears healed, but it is quiescent. We can always wake up. Does it eradicate? No, it does not. Then why the hell do we operate? Why do we do these surgeries when we cannot do anything about the disease? Well, we do it because of the way we are. We are living at a time when we look for hope. We have to do our duty. Please remember, do not let the fruit be the purpose of your actions. Therefore, you won't be attached to not doing your duty. Everything in our country boils down to going back to the Bhagavad Gita, and so it does in doing our job here. Please remember, it's a very pertinent question. Can we eradicate TB before it eradicates us? I don't think we can, but I know that it's going to let us live and it's going to live longer than each one of us. Thank you very, very much for a peaceful hearing. I hope that this presentation gives you that little sense of hope that we have in this war against tuberculosis. We may win a few battles, but the war is still not won. Thank you very much for a patient hearing.
That's an excellent presentation, and not only that, everything Dr. Chadda has covered, all aspects of spinal tuberculosis, but we'll not leave him now because, and Professor Thule is there. And any question before that, any question or any query to Professor Dr. Chadda? Any query? Any query, any part, anything, any aspect? Anybody, anything, wherever. Indications of surgery he has, or diagnostic point. I would request our teacher, Professor Thule sir, to say something to bless our students. Because, you know, the spinal tuberculosis, wherever you go in the world, not only in our country, and even you consult the book, foreign book of foreign authors, without Professor Thule's reference, there is no chapter on spinal skeletal tuberculosis. That is. So, sir, please, sir, few words.
Tolerates the deformity if it is occurring slowly. During slow deformity over years, the contents of the spinal cord, the neural elements, they have a degree of plasticity. Some columns may finish by deformity and disease, but there are some spare columns nature has left which get reactivated so that they can compensate for the loss of the neurons if the deformity is a slow process. If it occurs suddenly, patient will be paralyzed. I think there is one thing we should know. That is why the observation is there that paraplegia caused by tuberculosis has the best prognosis. There is paraplegia caused by trauma. There is paraplegia also caused by tumors. But the best prognosis of a paraplegia, if it is of tuberculous pathology, bright chances of recovery. And the reason is this: it is a slow process of deformation in which many neurons which are finished, they are compensated by neuronal plasticity. But a time comes when all the available neurons or neural tracts which could be plasticized have finished. And then you start having paraplegia of late onset. Deformity is there. There was no paraplegia for 3 years. After 3 years or 4 years, paraplegia occurred. And the reason is, by that time, many neurological tracts have vanished. Whatever could be induced to form new neurons or neural tracts, they have finished. Another thing, I think what Dr. Prabhu said, I think it's nice to keep on remembering it, especially we as medical people, dealing with the patients for the whole of your life. Keep up your immunity. Most of the immunity we can maintain by good diet to save our own self. Good diet, healthy lifestyle, and a biological clock of activity of the human machinery. Another point I would add, Dr. Prabhu mentioned, there's nothing like healing. I think we use a slightly different expression. He means the same thing. Tuberculosis cannot be cured, but it can be healed. So what we achieve by all the techniques, anti-TB drugs, rest, nutrition, operation, fusion, all we are achieving is a healed status, not curing. Microbes are still sitting in your body. In the macrophages, they are comfortably sitting. And they are under control so long as your cell-mediated immunity is under control. The moment the immunity comes down, that microbe, which has been sitting quietly for 70 years, can get reactivated. They are only looking forward to a time when your immunity goes down and tuberculosis will start. And I'm sure as students, as young doctors, you all know what decreases the immunity. One, poor nutrition. I keep on emphasizing on medical people, please maintain your own immunity, and these are a few steps which can help you. Long use of steroids, long use of chemotherapy for malignant conditions, and of course, HIV, etc., etc. These are the reasons. I don't have to say anything else. And I think we talked about neuroscience, but we also talk about deformity. Nobody likes to have a deformity more than 30 or 40 degrees. You still have to identify, and the best time to take care of the deformity is not when it has already occurred. Correcting a severe deformity, fixed deformity, is not without risk. People do it, but there's always some degree of risk. Identify a person who is likely to get a deformity. One, if the vertebral bodies are destroyed in more than 3 vertebrae. If the patient at the start of illness is younger than 11 years, and if the disease is situated between C7 to L1. This is the location, age, number of the disease, then your own observation. Have a look on the patient today. Take a lateral view, so simple. After 3 months, take another lateral view. After 3 months, take another lateral view. Compare. If the deformity is increasing, put up that patient for surgery for appropriate posterior spinal fusion. But for all these procedures, you do need bones. From a child, it becomes sometimes difficult to get adequate bones. Take autogenous bone, supplement with allogenic bones, that helps.
Say something about the duration of your recommendation of treatment, recommendation and duration of the drug. I mean, because you always refer to your name, how long you will continue the APR.
He's a very gentle man, you see. He will not fight with me in front of you. Later on, we'll keep on fighting. I still believe we must continue the medicine at least for 18 months. I keep on writing, speaking in the book also. Fortunately, it is even given in Grammar Play. Yeah, Grammar Play's book. Even they have accepted it. What I wrote, they have accepted it. First phase must be intensive phase. Beautifully given the name. It's an intensive phase where we must give 3 or more drugs. Now the duration would vary. It can be anything between 3 months to 5 months to 6 months. I give it for 5 months. So after 5 months, according to me, the intensive phase is over. Then should start maintenance phase. And in the maintenance phase, 2 drugs are enough. And then the last 3 months should be preventive phase. The last 3 months, we expect that the person has gone back to his place of work, to his place of environment, to his place where he got the disease. So let him have 3 months preventive phase. Total duration, 3 months, no less than 2 drugs at a time, and every combination must have isoniazid as a part of it. Second line drugs are extremely toxic. They require more care. I feel that fluoroquinolones, we should in our country consider it as a part of first line drugs, should not consider it as a second line drug. I use it as a first line drug. If you have any questions, I'll answer.
Any question you have? So really appreciate moment that we are happy that our research surgery on spontaneous surgery. Then finally we will get our future. Anything else about faculty?
What is the surest? This is a very difficult question, really. Can we prove in every case 100% rich man accepting or a rich country accepting that this is tuberculosis? Not in every case. And I keep on insisting, the moment you obtain a tissue, aspirate, fluid, lymph node, you must subject it to 3 tests. 1, histology. 2, microbiology. 3, serology. All the 3 must be subjected to. If you are smart enough to do a biopsy from a knee joint, look at the lymph nodes as well. Remove a lymph node as well. Send 2 tissues. So try to get a tissue which you can send it to the pathologist for histology. In we would mean they would do a microscopic microbiological examination, pathogenic, tubercular, fungal, other, and serological examination. Despite putting all this material for a large number of patients, whatever we learned or whatever I've seen, at least the place where I work and the type of the patient I get, I'm a physician to a common man. Probably the poorest of poor, I took after them in Banaras Hindu University. But even after that, I'm taking care of the middle class people. In 20% of people, we could never be sure what we are dealing with. In 80%, we will get the information from this tissue. So, in the remaining 20%, what is to be dependent? Your clinical judgment and careful assessment. And write it down. I write it down. Best clinical diagnosis is tuberculosis. Histology, microbiology, and serology has given us no information. This is how we go for taking care of yourself legally. Sure. Sure. But see, I mean, having done all this, write it down on the first day page. Write it down. I have done, we have attempted histology, microbiology, serology. There is no conclusive report given to us. I'll keep the patient under observation. The best clinical diagnosis is start anti-TB drugs and observation. All this must be written on the first page. We have to write it down. Well, I know of a case in which I had to face the court. Fortunately for me, it was written, looks like tuberculosis of the vertebrae. Within bracket, I had treated his wife for tuberculosis paraplegia. However, tissue diagnosis is needed. This was the sentence written by me on that first page. And in that particular patient, when we did the histology, it turned out to be a highly malignant mesenchymal tumor, mesenchymal tumor from the vertebral body. So it's a great mimic. Doctor ne bataya aapko. It's a great mimic. Tuberculosis can mimic any pathology, and any pathology can mimic tuberculosis. It holds true even today, even in the richest countries of the world. And he mentioned, I'm repeating it again, I know I'm probably taking too much of time. Tuberculosis has existed on this earth since the arrival of a living creature on the earth. Tuberculosis in the bird, avian tuberculosis. Tuberculosis in the fish, marine tuberculosis. Tuberculosis in human beings, human tuberculosis. It is still there.
Based on the clinical and radiological findings, we can start.
So, based
Because
upon
in our country, we cannot go for the city-guided pathway always for microbiological study or
one can. You see, fortunately, MRI is a great help for the new generation, and we should be, well, you see, the clinical sense has to be developed by all of us. And again, after all, even the latest investigations like MRI, CT, you can see how beautifully they write. They say they are imaging modalities. Look at the statement. They still do not say that we know the diagnosis. These are, and at the end, almost all last sentence would be, the diagnosis suspected is this. However, clinical correlation is essential. You see, I mean, look at this thing, highly sophisticated investigations like MRI, PET scan, CT scan, beautiful investigations. They have changed the whole thinking. This man did not live with this one. Up to 87, there was no MRI available in Delhi. The first MRI came in a defense organization where I used to go whenever I had time. I spent 100 hours with them to learn a little bit of MRI. But the beauty of this newer investigation is they still write, we are imaging modalities. This is our diagnosis. However, clinical correlation is essential. So it will continue like that.
Thank you, sir.
Okay.
Thank you, Dr. Chandra.
Thank you so much. Hey. That's right. Oh, okay. Wish you all the best. God willing, we meet.
Next important part in the examination, we get in the physical examination, a bony swelling. Bony swelling. What to do? How to diagnosing, differential diagnosing. Dr. Joseph.
Oh, humor. No, it's okay. That's just info. It's wonderful to question.
In the past 1.5 hours, we were all indulged in the ocean of spine, tuberculosis, and spine. We all just like hypnotized on the surrounding what's going on. But now, again, for the another part, I will be talking about the swelling. Since morning, you are well versed with how to examine the swelling, what are the important points you have to put stress for the examination purpose, what a history you have to take. I will just summarize all these points as far as bone is concerned. That is the bone tumor. Then I will make a simple try to classify the tumors and how to diagnose the tumor. The basic step, that is your biopsy. So what the principle I have to follow for the biopsy. So what may causes the bony swelling? First one is injury, trauma. We all know it can be infective, it can be degenerative. Autoimmune disease also sometimes they present as the swelling, and the carcinoma, which may be benign or the malignant tumor. Which are bone tumors are characterized by puffiness, pain of skin and tissue overlying the bone. It will be tender. It may be red and the warm to touch, and the mobility may be limited. It may be or may not be skin over the tumor may be mobile, it may not be mobile. If the bone swelling is caused by an infection, fever, chill and nausea may be accompanying. So before doing the diagnosis, we have to proper history is the key to diagnosis. Age of the patient, there are the tumor which are present since birth. They can present at the adolescent, example fibrous dysplasia, at any age, tuberculosis myelitis and the Pegas disease. So coming to the onset, how the tumor arises, whether it was gradual in onset, it was the sudden onset, so how long since the tumor was found, whether it was found accidentally or someone pointed out. Then what happened to the swelling since it was detected, whether tumor is swelling size increasing, it is constant or it's decreasing. Then any history of the trauma. So if the tumor is associated with pain, all the relevant history of the pain you all of might know very well. Site, size, duration, any aggravating factor, relieving factor has to be taken into the account. Was the pain during the rest or only get aggravated by the movement? Then another question from the bone tumor point of view is which came first? Whether swelling was first or the pain was the first. Then any history of the previous surgery when you are dealing with a bone tumor, most of the time when the patient encounters us in the clinic, he has some scar, which denotes some handling has been done with the swelling. What was done? That was the biopsy. Then any other medical comorbidities which will help in our planning. Then personal history, family history. We all know there are some disease which runs along the family like OI, achondroplasia, etc. Then as already everyone told, before going for examination, there are some protocols which must be followed. Introduce yourself, explain yourself and ask the patient what you are going to do. It's very, very important. As I told, there should be consent with each and every step, each and every procedure. Exposure should be sufficient. Underexposure may lead to problem for your examination. Then define the position to the patient and utmost thing treat with respect. General examination, we already know appearance of the patient, anemia, icterus, cyanosis, clubbing, etc. For us, what is important is your lymph node examination because tumor will metastasize. Relevant lymph node, why we have to come to know, because when going for the surgery, the concerned lymph node has to be taken out along with the tumor mass. Then body temperature will be raised or not, then pulse. So in addition to that, what extra we have to examine the chest for the consolidation and the pleural effusion, especially in case of GCT. We know GCT will metastasize to the lung. Liver, for the secondaries, we have to go for general examination of abdomen to find out any peritoneal metastasis. Always examine for this, include the spine, pelvis, and trochanter of the femur and skull to exclude any metastasis. So when there is a multiple myeloma or any secondaries from the unknown primary, these are the sites which are most commonly involved. So going to the examination, inspection, in addition to the swelling proper, we have to inspect the limb. Limb for the condition of neighboring joint and pressure effect of swelling, if any. For the swelling examination, we all, as usual, we have to see for the size, shape, surface, skin overlying swelling, is it ulcerated, any surrounding area, whether it is hyperpigmentation, hypopigmentation, border of the tumor, it is ill-defined, well-defined, the number of swelling. There are a few conditions like neurofibromatosis, with multiple swelling. Then color and age of the tumor, swelling. In the palpation, all the finding of inspection should be confirmed first. You have to confirm. First, go for the local temperature, which you have to see by the back of your hand. Then tenderness, whether the tumor is tender or non-tender, and also see for the inflammation. What we commonly see site, there are some tumor which are in the epiphyseal predilection. In 90% of cases, we will get osteoclastoma and GCT in the epiphysis. But there are instances where we have got the GCT in the metaphysis and the diaphysis also. So I'm not saying it's 100%, but 90%, 90-95% cases, site predilection is there. Like similarly, osteomyelitis, osteosarcoma, Brodie, osteoma, all are the metaphyseal tumor, while Ewing sarcoma and the multiple myeloma has the higher predilection for the diaphysis. So shape of the tumor, which is a diffuse, peduncular, or spherical. Most commonly, what we get osteochondroma, we will get a clear peduncle, which will always go away from the joint. Then surface over the swelling, whether it is smooth, lobulated, or rough. Margin, well defined or ill defined, that I will discuss in the further slides. Consistency of the house is the swelling, whether it is the doughy, it is the bony, hard, firm, fitting or not. Then we get, as a bone ortho-oncosurgeon, we get very limited pulsation. That is only one is vascular tumor, that is the inguinal bone cyst. On the auscultation with the stethoscope, we can see the murmur sound of thing. Then bone irregularity, if there is the osteomyelitis, most of the time you might be saying osteomyelitis comes in my talk, because this is one of the close DD for any bone tumor. What commonly is in the pediatric age group, Ewing sarcoma. X-ray wise, it's very difficult to diagnose whether it is the Ewing's or osteomyelitis. Is there any presence of ulcer or sinus? Then we have to also examine the neighboring muscle, whether there is muscular wasting or not. Then we have to see for the fixity of the skin. How we see the fixity of the skin, you might have already learned in the previous classes, previous lectures. Then we have to see for the how the swelling is related with the underlying structure. It can be located, it can be related with the muscles, with the tendon, with the vessel, or the bone. If it's bone, it will be fixed. If it arising from the vessel, it will move up to little extent at right angle to the axis. If it arises from the tendon, it will move with the tendon and it will be fixed. For the ortho point of the view, localized tenderness in case of the abscess is only sign when we have to go for the percussion, and auscultation is only for the pulsatile swelling. Measurement of the limb lengthening or shortening, whether there is a muscular wasting or not, that we have to find it out. Now going to the classification of the tumor. Based on the tissue of origin, we classify the bone tumor on the tissue of origin, from where it came from the bone, it came from cartilage, fibrous tissue, bone marrow, blood vessel, mixed, or it was uncertain origin. So all the tumors arising from the bone, it can be benign or the malignant. In benign, if it arising from the bone, it will be the osteoma. Osteosarcoma will be the malignant counterpart. Cartilage forming tumor, chondroma, will be the benign. These all chart you will get in the book, textbook. So I will skip this one. Now we have to go for the whether you have got a swelling. So we have to find out is it benign or malignant. This is the basic question what you will ask in examination. So history part we have already seen what all history you have to take. Now we will go for the directly X-ray. What are the feature which will suggest whether it is a benign tumor or it's a malignant tumor? So what you have to see in the X-ray? You have to see the border, you have to see the matrix around in the tumor, you have to see the periosteal reaction, you have to see the loss of the matrix, site, soft tissue extension, whether it is there or not. I will see, deal one by one everything. Coming to site, this is the pointer here. So this portion, on this side, we will see the all the tumor common predilection side. I am always telling it's not 100%. It's up to 95% is the common predilection. It tumor can fluctuate here and there. So if it is in the epiphysis, most common diagnosis will be your chondroblastoma. Osteochondroma, it's always peduncular tumor away from the joint. This will be your joint, so it will be away from the joint. There will be inchondroma, non-ossifying fibroma in the diaphyseal lesion, ABC in the metaphyseal lesion. Now going to the adult, we can have GCT in the epiphyseal lesion. We have osteosarcoma, fibrosarcoma in the metaphyseal lesion, and chondromyxoma, erymantinoma, metastasis in the diaphyseal lesion. So this is the X-ray, what we commonly see. This is the periosteal osteosarcoma, metaphyseal area. Chondroblastoma, you can see the epiphysis is not fused, epiphyseal lesion, chondroblastoma, and in the diaphysis, it's a erymantinoma. So after that, where the lesion is located, it can be central, it can be eccentric, one-sided, it can be cortical, rising from the cortex. It can be periosteal, common variety periosteal osteosarcoma, what we get, and it can be intra-articular. In the vertebra, most of the malignant lesions are seen predominantly in the body of the vertebra, exception being hemangioma and the fibrous dysplasia. And in the all the benign lesions are in the posterior body of the vertebra. Benign lesion. Now coming to the border. If we get the sharp sclerotic border, it shows tumor is benign. Whether when body is ill-defined, it's a highly malignant tumor, and sharply lytic lesion, it's in between. You can see this X-ray, the border around the tumor is clearly we can see we can find out the border, that is the sclerotic border, and diagnosis was come out to be the non-ossifying fibroma. While we can see there is an aggressive malignant lesion involving the iliac bone. Then pattern of bone destruction, we can have the geographical pattern destruction suggesting the benign nature of the tumor, while there will be permeative, it will show the malignant nature, and the in between you have the moth eaten. We can see in the X-ray, giant cell tumor, nicely geographical lesion is there. In the myeloma, we get the moth eaten, and the Ewing sarcoma, full permeative lesion. Then the periosteal reaction, it can be uninterrupted or interrupted. Uninterrupted periosteal reaction will figure out towards the benign lesion, while interrupted will face toward diagnosis of the malignant lesion. Different types are there. It can be solid buttress, solid longitudinal. In the interrupted, it can be perpendicular, sunburst, onion peel, Codman's triangle, etc. So these are the picture. We can see the sunburst appearance in the osteosarcoma, onion peel, this one, that is Ewing sarcoma. These are laminated. It is the zoom view. You can see the Codman triangle here. It's a diagnostic of the osteosarcoma. Then a type of matrix. In the tumor matrix, it can be osteoblastic or it can be chondroblastic. So if there is a fluffy cotton-like density within the medullary cavity, it's diagnostic of the osteosarcoma. When there is the wisp of tumor bone formation in case of osteosarcoma, and there is solid sclerotic mass also seen in the case of the periosteal osteosarcoma. Matrix can be chondroid, it can be stippled, flocculent, and ring in the arc. So now the another question what we will be asked, whether tumor is basically arising from the soft tissue or it's coming from the bone. So how we can differentiate? These are the primary soft tissue swelling, which is main tumor will be outside the cortex, while the tumor in the bony swelling will be inside the cortex. The cortex will be towards the bone, while it will be outside the bone in the bony swelling. The periosteal reaction will be absent in case of the soft tissue swelling, while we will get the nice periosteal reaction. Different already told. Then there will be small bone lesion, large soft tissue mass in the soft tissue swelling, while there will be large bony lesion in the bony swelling. So summarizing all the points in a single slide, benign lesion will have the well-defined sclerotic border. It will lack the soft tissue mass. There will be solid periosteal reaction. There will be geographical pattern of the bone destruction. While the malignant lesion will have interrupted periosteal reaction, more threatened or the permanent bone destruction with a large soft tissue mass, and there will be the wide zone of transition. Now, after getting the information about the benign nature of the tumor, we have to classify it. What we commonly practice nowadays is the Anakin classification. And here we classify benign tumor as a latent, active, and the aggressive, while the malignant tumor are classified in the 3 grade, 1, 2, 3. 1A have the intracompartmental tumor, 1B have the extracompartmental, grade 2 has the high grade with intracompartmental, 2B is high grade with extracompartmental. If there is any metastasis, lymph node metastasis, it will be grade 3. Now coming to the bone biopsy. Different type of biopsy are available: needle biopsy, core biopsy, incisional biopsy. What we commonly do nowadays is the core needle biopsy, which has got the around 90% accuracy rate. Now going to the tumor biopsy principle. Biopsy done only after when the evolution in the imaging is complete. We should not jump direct to the biopsy. Before biopsy, all the X-ray, MRI scan, if required PET scan should be done. Then only jump to the biopsy. It will determine the aesthetics and the local extent of the tumor and the metastasis. Staging helps determine the exact anatomical approach to the tumor. Biopsy superimposes radiological changes at the biopsy site, and therefore can alter the interpretation of the imaging studies. That's why always all the MRI and the PET scan should be done prior to the biopsy. Then we should place the small incision whenever possible. The biopsy tract should be considered contaminated with the tumor cell. So when the final surgery has to be done, the biopsy tract should be taken out along with the tumor mass. The surgeon should be familiar with the incision for the limb salvage surgery, and hence it has been said that biopsy should be done by the same surgeon who is planning for the different surgery or under his direct supervision. So these are the important slide for you. These are the, you can see there is the biopsy, brain tract was taken through the patellar tendon. Ultimately, we could not get any extensor mechanism, or limb has to be amputated later on. Then, if the tourniquet is used, the limb should be elevated before inflammation and avoid extubation. So you should not excuse that what we commonly do in the trauma surgery. It should not be done for the tumor surgery. And contaminate as little tissue as possible. Go the intramuscular plane rather than intramuscular plane. What we follow in the trauma surgery, we used to go through the in between the muscles. But for the tumor biopsy, we should contaminate a single muscle. Avoid the transverse incision. The deep incision should go through single muscle. Major neurovascular bundles should be spared. Otherwise, limb will be non-functional. There should be minimal retraction, so should be utilized to avoid soft tissue contamination. So biopsy tract should always be in longitudinal one, it should not be transverse. These are the diagram we show through which tract, when the location of the tumor in the proximal femur, how we should proceed for the biopsy. In the lateral femur, how we should proceed. In the proximal, the distal part. Then, if possible, soft tissue extension of the bone lesion should be sampled. And if we have to for the biopsy, if we have to make the hole, it should be round, circular hole, so that there should be less stress concentration. And biopsy should be taken from the periphery of the lesion, which contains the most viable tissue. Another point. What most of the time, what we will do, we'll go in the necrotic area when there is the center of the lesion. The report will say blood and the necrotic tissue seen, no viable tissue found. So biopsy will be taken from the edges, where we can get amount of necrotic tissue, also the healthy tissue. So this is a picture diagram which shows the bony cortex should be made in circular way. It should not be rectangle or oval. And if there is any associated pathological fracture, biopsy should be taken away from the fracture site, not through the fracture site. Then drain. This was the biopsy incision. Drain should be in the line of incision. It should not be too far. It should be as close to the skin incision, but in the line. It should not be in another one. So take home message is the complete and thorough history is an important and integral part of accurate diagnosis, which is well supplemented by A to Z clinical examination. Investigation will just confirm our clinical diagnosis. Thank you.
These are the steps of examination. 1, listen. 2, look. 3, feel. 4, move. 5, measure. And when it comes to measurements and movements, always compare. This is what it is. Listen properly. Listen, look, feel, move, measure. Movement and measure, compare. Most of the time, you have a normal link to compare. And you learn so much by comparison. Almost everything you learn. Look, movement, size, shape, range of motion. And then next step, almost in every orthopedic, would be an X-ray. Again, if it is an early case, you ask for an X-ray for comparison. Even a micro fracture would be visible to you. So I have used the word compare. Compare both the wrists. Ask for an X-ray both the wrists. Patient doesn't have to spend much money there. Hip joint, take an X-ray of the pelvis. Elbow, put the elbows together, ask for an X-ray, comparative X-ray. So this is how we say compare clinically, measurement, range, and X-ray. This is what should your clinical setting should be in your mind, brain, and finger. And then every time today, in today's scenario, in rich countries, a patient doesn't like to be touched again and again. In our country, somehow we have been up to this time touching the patient again and again. I think the psyche is changing. So we should ask, well, madam, I'm going to examine you. Give me about 5 or 10 minutes, I'll examine you. But don't get into the habit, examining, आधा कर लिया, फिर जाओ, फिर याद आ गया, दोबारा करने लगे. That nobody likes, no patient likes. Rich, middle, even poor may not like it, particularly the ladies won't like it. My friends, you can develop eyes on the tip of your fingers. Touch, feel, move. You'll be able to judge many things through the fingertips. Put your hand on the spine. You'll be able to judge which vertebra it is. Is it a single vertebra involvement, 2 or 3 vertebrae involvement, more than 3 vertebrae involvement? Is there a kyphosis? Is there a kyphoscoliosis? That sort of thing. I think you saw a beautiful illustrations. Uh, when we talked of, well, we had the full cream of tumors of the skeletal system, but when we come to vertebral column, if you can remember a few sentences. The commonest benign tumor of the vertebral column is a hemangioma. The commonest malignant tumor of the vertebral column is a secondary deposit. The commonest primary malignant tumor of the vertebral column is a myeloma. Just keep that in. Primary tumor, primary benign tumor, hemangioma. Primary malignant tumor, primary, would be a melanoma. And in general, if we talk of malignant tumor of the vertebral column, the commonest malignancy of the vertebral column is a secondary deposit. These are certain things which one can remember. And there are certain conditions which are generalized. See, you are looking at a patient with TB of the knee joint. You send the patient for the X-ray. I would probably send him, if it's an early case, X-ray both the knees. Also ask for an X-ray of the chest. Don't do that. Nobody likes these days. I say, abhi X-ray karwa ke aa jana, then I'll write down for an X-ray of the chest. You are suspecting tuberculosis. Why not have an X-ray chest also done in the same sitting? And the same principle should apply even to neoplastic conditions. If you're suspecting myeloma, if you're suspecting metastasis, if you're suspecting things like fibrous dysplasia, or if you are suspecting syndromic conditions like osteochondroma, chondromalacia, multiple end chondromatas, then again ask for an X-ray of the pelvis in the first go. Skeleton of the pelvis gives you information regarding all these conditions. Myeloma, there may be it's a very favorite thing for myeloma to have deposited in the pelvis. Same as secondary deposit. And then, just as we say, infection, very favorite place for an infection to be present in the lungs. Similarly, many of these humorous conditions have a very favorite place to have another lesion in the pelvis. Fibrous dysplasia, osteochondroma. At this time, I may not be able to remember many things. Osteochondromatas, multiple chondromatas, and I think these are there are many benign tumors which are multiple. Do ask for an X-ray of the pelvis, you will be rewarded. Okay. Wish you all the best.
এখানে তুমি এখানে এসো
দিও না
হ্যাঁ 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 এখনো দিও না এখনো নট নাও নট নাও নট নাও this one okay it's okay it's okay just bas it's okay no, now I'm not going to start now. Should we start now? I will not read it. You will read it in 2 minutes and 2.5 minutes. Okay, 2.5 minutes. If you, I will just ask you that whether you have finished it. And if you say yes, then I'll go to the next question. The question 1 starts now. As short as possible answer. Thirty seconds left. Have you finished? Now going to the second question.
Changed. No, the same. Is it the same? The last question. First, what you will do, you just submit write your name, email, WhatsApp number, and they submit the paper, and then we'll discuss the answer. Sir is here. Hey, collect the
collect your name and email address. In email address, I will send you your number. You can ask. Now we will discuss about the answer. Yeah.
Okay, sir is there. So actually, I shall request to our sir. So is there any ambiguity or any questions, any doubt? Please clarify this. Yes, please, sir. Please. Yeah, definitely.
Lateral peripheral disease, right hip as well as the left hip. Both of them deserve to be taken care of by a surgical procedure. We call it covering the peripheral head. Now there are two methods, broadly speaking, there are two methods of covering the femoral head. One is by a upper femoral osteotomy, do a varus osteotomy, so that the head sits into whatever acetabulum is available. It is expected that the acetabulum will remodel. Unfortunately, the remodeling of the acetabulum becomes minimal after the age of 4 years. Make a note of it. There are some osteotomies prescribed by many surgeons. They expect the acetabulum to remodel to the size of the femur. Unfortunately, that happens predominantly below the age of 3 years. After the age of 3 years, the remodeling of the acetabulum does not take place. So many people will say, okay, I will make the acetabulum broader by doing what we call pelvic osteotomy. What is called osteotomy at the waist of the pelvic bone. In reality, in other words, if I put the simple word, supraacetabular osteotomy, coming from the anterior margin of the greater sciatic notch up to the anterior inferior iliac spine, make a complete cut, shift the lower fragment medially so that the upper fragment forms a shelf on it. So this is one. Now, if both of the sides require that. The left side is more deformed because if you see the Shenton's arc, you'll be able to think of it. Shenton's arc is much more deformed or much more disrupted in the left side. Right side, it is not much disrupted. Third, but when you see a patient of bilateral perthes, you think of a dysplasia. It is in reality not perthes. So you become more thoughtful, should I put a knife? That debate must be kept in mind. Bilateral perthes in general is considered a generalized dysplasia. Sometimes these patients do require procedure, but with complete understanding, it is not a unilateral perthes. We are dealing with a case of skeletal dysplasia, and we are trying to improve the function of that hip joint. These are two different things. Perthes is very different than a generalized skeletal dysplasia, but generally, when you find a bilateral perthes, generally it is considered a part of skeletal dysplasia. Okay, I wish you all the best. I'm very happy to see you all, and these two young ladies around.
Very happy and excited to see you here.
I entered into the academic chair, and I was operating, and I was The institution had the first batch of MBBS students, and they were watching. And the lady, one of the girls, first batch is usually pampered. So those girls said, "Sir, we want to see the professor of orthopedics who has joined here." I think you're speaking to him, I said. No, sir. I expect a huge body, broad man. Then I had to tell her, Beta, today's orthopedicians do not need forces, they need techniques. And I'm sure you as ladies can also, you are also welcome to join. But nobody joined.
Young teacher is in front of you, only 92.
My age is being increased at every function. And I will never do that. I won't tell you the truth of the age. My grandchildren celebrated my birthday and they increased my age by 2 years. And then somebody gave me an injection. Again, it was increased by 2 years further. Okay.
All confidence with the what is it?
One should also know the definition of floating knee injury. Your patient number 2, no, your patient number 3 is a floating knee injury. Okay? Okay, Bacho, wish you all the best. God willing, we keep on meeting.
Thank you very much.
Thank you very much. Thank you very much. Nice seeing you.
It's our pleasure, sir.
Yes. Thank you very much. You permitted me to be around.
No, sir. And sir, this way. With the
Just sit for a few minutes. Just have completed the answers. Answers. Please give the PowerPoint. Please give the PowerPoint. Okay. So that is what is the deformity? What is the see? This is basically it's a cubitus varus deformity of the left elbow. What is the commonest cause? That is a malunited supracondylar fracture of the humerus. Okay. Now, what are the points of the palpatory finding of the what are the expected palpatory findings of supracondylar ridges if it is due to trauma? So it is a thickening and irregularity of the both the supracondylar ridges, which motion should be lost of the shoulder. Basically, is the external rotation of the shoulder will be lost at the cost of increased internal rotation, which is contributed by the malunited component of the supracondylar region. Okay. Now, how to quantify? It's clinical method of quantification and this deformity are with prerequisites. Basically, you have to measure the carrying angle, and the prerequisites of measuring the carrying angle is that the elbow should be fully extended and forearm should be fully supinated. Okay. Now, the most common method of surgery is the lateral close wedge modified French osteotomy. Okay. Every word should be written in the examination. Now, this is the way, this is another problem. So the question is enumerate two possible clinical diagnoses. See, there was a history of intermittent fever. There is no history of high fever. So infective component is relatively less. Okay. So as it is a 10-year boy, so and there is a weight loss and feeling of tiredness of 4 months duration. So it will fit on the malignant tumor category. So this first choice should be the malignant neoplastic swelling from the tibia involving the posterior compartment, maybe the Ewing's tumor or any other malignancy from other region. You have to write malignant, that's all. And there is a chronic infection. Most common is the tuberculous arthritis, 4 months intermittent fever. So with systemic feature, so tubercular arthritis of the ankle with cold abscess in the extravasating on the posterior compartment, or tubercular osteomyelitis of the tibia involving the ankle, or rarely tubercular synovitis. Now, the two inspectory findings of the leg and ankle. First is a large diffuse swelling of the back of the ankle and the lower leg. And next is the plantar flexion ankle. Plantar flexion, you can see, you can write it down either equinus deformity or the plantar flexion deformity. Next is the two most relevant palpatory findings in this case to ascertain the nature of the swelling. The swelling may be neoplastic swelling, maybe infective swelling, maybe bony swelling, anything else. But two most important is the local temperature. And most important is the raised local temperature and local tenderness over the swelling as well as over the tibia. This is most important. Just local tenderness over the swelling is not sufficient enough. So we have to see whether it is maybe soft tissue swelling may be same, but if it is a local temperature on both the side, that may tell that may clue that the swelling is coming from the bone. Next is this mentioned to how to ascertain the swelling is coming from the bone or soft tissue. So this is a continuity of the swelling to the tibia and its mobility. I just previously in the morning we discussed about mobility in relation to the tibia and soft tissue, including the tendo Achilles. Next is what is the distal complication? Distal complication is the equinus deformity. And mention any clinical examination of the distant area. That means the lymph node examination, maybe popliteal lymph nodes, or maybe deep inguinal lymph nodes, or maybe external group of lymph nodes. Now, this is the 25 years old treated by this due to the closed floating knee injury with altered sensorium for last 7 days. The exact site of insertion of the traction pin is a calcaneal traction pin. It is basically, see, this is the calcaneal, exact side of calcaneal traction pin, that is anterior to the posterior 1/3 of the line joining the tip of the medial malleoli and the center of the medial heel. That is relatively much more posterior one. Much more posterior, because in the midpoint or just anterior to midpoint, the artery is passing. So we have to go, at least we have to insert the pin at least posterior to the midpoint. That is the clue. Then there is also, if more anterior, there is also a chance of injury to the medial calcaneal nerve also. Next is, which soft tissue complication will you expect from the improper padding of the splint? That is, the whole tendo Achilles tendon should be free of padding, otherwise it will be sloughing out. Okay, the which knot should be given. There is a Seller's knot or clovage on any specialized knot which is required for tying the rope with the bowler stirrup. Now, is the traction is working properly? Yes, no. Traction is not working properly as there is a no. See, there is bed end is not raised and it is almost touching the traction cord is almost touching the bowler strap is almost touching the end of the bed. Which iatrogenic complication of the foot will be expected from faulty insertion of the calcaneal traction? I already mentioned there will be medial calcaneal nerve injury that may lead to there is a cavus. See, there little bit cavus deformity is already seen here. This cavus deformity, it may be either due to higher injury or it may be to lower injury. If there is a local injury that can lead to medial calcaneal nerve and that may lead to intrinsic muscle paralysis. Otherwise, there is a I already mentioned it is only a floating knee injury. So if it is given some spinal injury, so that may be the feature of that. Okay, so always you have to read all the keys, all the hints very carefully. Now, how to dress the scale? Another if it is given for this only for 7 days. See, the traction is given for 7 days. If it is given for 3 weeks or 4 weeks, it is a prolonged traction. There is a possibility of stiffness of the subtalar joint. Okay, so here answer will be the medial calcaneal nerve injury. So the iatrogenic complication. Now, how to dress the skeletal traction pin? This is the universal answer of any type of pin, like external fixator pin, like dressing of any external fixator pin. That is you have to wash the pin thoroughly with the normal saline, and any non-irritant substance should be used, like the ciprofloxacin eye drop may be used. Never use the spirit or betadine. Never write it down. Okay. Now, this is a 38 years old male unable to use the left shoulder and bring the palm facing forward on the left side. So what is the deformity? It's basically a policeman receiving the tip deformity or waiter's deformity. So enumerate the probable losses of the function. So basically, which losses of that is the shoulder abduction and also shoulder abduction and external rotation, elbow flexion, and the forearm supination. Okay. Now, what is the cause? Basically, it is the brachial plexus injury, the off palsy, or the abduction paralysis, or upper roots of brachial plexus paralysis. Now, name the sign which detect the osteoarticular abnormality of the shoulder, identify the shoulder deformity. So basically, it is a sulcus sign or inferior subluxation or luxatio erecta of the left shoulder, basically. Okay. Now, which test, which relevant to investigation for confirmation of the diagnosis? Is the electrophysiological or electrodiagnostic or electromyographic test and the nerve conduction velocity study and the CT myelography, MRI or MR neurography. Any answer is correct. Any answer, if you write it down, either electrophysiological test, electrodiagnostic test or electromyographic test, it's one. Second is nerve, so muscle and nerve separately. Okay. Now, identify this is very common and is already discussed in the morning. So this is a gate is basically it is a Trendelenburg gate. Now, 3 possible causes, that means the differential diagnosis of coxa vara that are already stated in the morning. Now, which most relevant inspectory finding do you expect in this patient? That is the short short limb, there's limb length discrepancy. Okay, and then there is a possibility of the wasting, I already stated in the morning. The most relevant palpatory finding do you expect? Palpatory finding means that is the higher level of the SIS, adduction deformity or GT at a higher level. Okay. Now, which movement is normally should be restricted? That is abduction and internal rotation. Okay. Now, this is the 11 years old boy presented with the limping and the unable to cross-legged, provisionally diagnosed the Perthes disease. See, this is the abduction is restricted. It's almost it is 20-25 degree, but normal abduction of in this age group it should be 40-45 degree. So abduction is restricted. Whatever abduction is restricted in the hip extended, whereas this portion, that is patient is unable to sit cross-legged. That means during the cross-legged position, it requires flexion, abduction, as also little bit of external rotation. But here we want to highlight the abduction and the flexion. Flexion in abduction is basically, it is grossly restricted. This is also a component of the sectorial sign. In the sectorial sign, we usually see the change of the internal rotation in hip extended and hip flexed. But here, the flexion in abduction is also another component of the sectorial sign. It is highlighted here, which is normally is usually not seen in our clinical practice. So identify the clinical test as sectorial sign. What is the implication of this test? All of you know what is the implication, why it suggests it's a Perthes disease, because a mechanical defect of the anterolateral aspect, especially sectorial part. That means only the anterolateral aspect of the femoral head is affected. That is why it only goes when it goes inside the acetabulum, either by the abduction and flexion or abduction and internal rotation, then only it changes. So many others, a similar test is basically the rotational change in hip flexion and extension. Okay. Now another question is a 7 to 8 years old boy presented with limping for 1 year with pain over the right groin during walking and sitting cross-legged for 6 months, provisionally diagnosed with Perthes disease, which inspectory findings clearly visible, that is the limb-length discrepancy and also the vesting. Now mention the steps of the apparent quantification of the obvious abnormality, that means the ASIS. So I already in the morning, it is already stated, that is steps of apparent quantification, is apparent length measurement, apparent length, steps of apparent length measurements. Okay, the so first you take the consent, then the position, next the step by step. Next the limb should be parallel and parallel to the to each other and parallel to the axis of the body. Then we have to find out the most prominent, most important constant point is the xiphisternum or the suprasternal notch, and from that we have to go identify the medial joint line and the medial malleolus. We have to measure it on the normal side, then abnormal side. So these are the steps. Now, which inspectory finding is shown by yellow line in the figure 2? That is the abnormal position of the ASIS. So on the on the affected side is at a higher level, so it is a adduction deformity. Okay. Now, after palpation, which clinical method is relevant to confirm the abnormality? Okay, after palpation. So palpation is for confirmation. So and then only by examining the abduction adduction. So only the abduction adduction, if we want to, if we able to move the joint. Otherwise, if the joint is is difficult to move because of the pain, then the Cotaris angle. So these are the two palpatory methods. Next is the mentioned two methods of quantification of the abnormality. So quantification is again, it is due to either by the squaring of the pelvis. There is a classical method. Another is the Cotaris angle. Okay. Another is 11 years old boy presented with pain on right groin during the walking for last 1 year. Enumerate at least 4 radiological signs. So the radiological signs is the sclerosis. Sorry, is a sclerosis. Is flattening. Is lateral extrusion. See, is lateral extrusion. And see the greater trochanter is higher up. How do you know the greater trochanter is migrated? That means the growth of the proximal femoral epiphysis is retarded. The highest point of the tip of the greater trochanter should be at a lower level than the center of the head. Okay, here it is almost at a higher level. Say suppose center of the head is like over here. The tip of the greater trochanter is at a higher level. So this is a 4 point. And also the neck is broad and the coxa brava. So these are the 4. If anyone you can write. On the right side, so there is a sclerosis, reduction of the height. There is a metaphyseal cyst. There is a large, there is a coxa brava and coxa vera also there. There's a mild subluxation. If you draw the Perkins line, it is a mild subluxation. Okay. So on the both sides, identify the radiological stages. Yes, the radiological stages. See, it is sclerosed. It is fragmented. So it is crossed 2. Now now the remodeling started. See on the lateral aspect of the epiphysis. Lateral aspect of epiphysis is the bone is come. If the bone is immature, that means texture is below the normal, less than the normal sclerosis. It is 3. That is remodeling stage 3A. But if it is a mature bone, it is 3B. Okay, so it is a 3B actually. So in the right side is a 3B, whereas on the right side is wholly sclerotic, reduced height, but it is not, no fissure has come. No fissure has come. So it is a stage 1B. 2 has not come. If it is a fissure, single fragmentation, multiple fragmentation, it will be 2, but it is a 1B. Head signs on both femoral head. There are all the which is features. All are head signs. Which side carry the bad prognosis? Definitely right side, as it is a 3B. Okay. 11 years old boy presented with pain on the right groin during walking for last 1 year. Mentioned 2 probable causes of pain. So this is also as rightly mentioned, with a bilateral Perthes, you can suspect that there is a possibility of epiphyseal dysplasia. Okay. Now, what is the cause of pain in this case? In the epiphyseal dysplasia, there is a progressive deformity, progressive problem, and there is a pain is basically due to the mechanical irritation. Because of this, as it is sphericity is lost, mechanical irritation or due to hinge abduction. Basically, these are the two causes. Okay. Mention the way to detect this. That is the how to detect whether it is a mechanical irritation or due to the hinge abduction. So mechanical irritation, that means you have to see the sphericity with the help of the orthogram. This is most important. Another is the how to identify the hinge abduction. That is the whole that we have to take the anteroposterior radiograph with as much as abduction is possible, and as much as abduction is possible, we have to take the anteroposterior radiograph. So if you see the medial joint lines, medial joint space, normally if it is a concentric hip joint is concentric one, so medial joint space should be equal when the hip in is neutral position and in full abduction. But if this medial joint space is measured by this medial most point of the epiphysis and the teardrop. As you can see here, this is a teardrop, this is the medial joint space. So on an attempt to do the abduction in the anteroposterior view, if this medial joint space is increased, that indicates this is a hinge abduction. There is a false abduction is occurring on the leverage of the lateral edge of the acetabulum. Okay, so that is the two way to detect the sphericity and the hinge abduction. Now outlining the management of the right hip. It is 11 years. No containment operation can be done after 12 years. 12 years is the cutoff time. So it is 11 years. We can do the containment, but it is a very bad prognostic indicator. Okay. Otherwise, if it is 12 years, it crossed the 12 years, there are some separate salvage surgery we can done. Okay, there are different salvage surgery we can done. On the right side, as it is a stage 1B, is 11 years, we can do rightly the containment operation. Okay. So 45 years old female sustained this following fall on slippery surface, which palpatory clinical finding. This is the anterior hip point tenderness and the trochanteric tenderness, not the bitrochanteric tenderness. If you write bitrochanteric, it's a wrong answer. Okay. Which radiological parameters to be searched here to denote the fresh fracture or non-union? Okay. So, so fresh in non-union, what will happen? The fracture end should be rounded, sclerotic, and there will be absorption of the bones on both sides of the fracture side. That is on the head side and on the neck side. So the in non-union, but in the fresh fracture there will be not such cases. How to classify this fresh fracture? So it may be a categoral classification. It is completely displaced. As you can see, the lesser trochanter is completely visible. This is completely displaced, stage 4, and this is Powell's classification. So it's a fresh fracture. Okay. So this is Powell's classification. See the angle. So this is the angle. See, this is the angle. And this angle, if you make a horizontal, it is more than 50 degree. So it is a Powell type 3. Now enumerate the 2 clinical factors and 2 important radiological factors before plan of treatment. So 2 important clinical factors is, one is the age, next is the duration of the, or the comorbidity, duration of the fracture or the comorbidity. Okay, comorbidity. And important radiological parameters and factors before plan of treatment. It is basically, radiological parameters is, what are the radiological parameters? That is basically, you have to see whether it is a avascular necrosis or the significant absorption of the femoral heads. So in that case, the salvage surgery can be, the osteosynthesis is very difficult. We have to go by the extensive osteosynthesis or by the joint replacement. And another the question is okay, thank you. So this is the question. So if you have any doubt, otherwise we will call up the day. Over to Dr. Roy.
Thank you very much. And see you next time.
ఫస్ట్ నుంచి పెడతా. Okay. Last is not there. Last key not there. 1 minute. తీసుకొస్తున్నా. జల్దీ తీసుకో. వాడు చేస్తున్నాడు అక్కడ. టేకింగ్ ద ఫోటోస్. అంతే ఆన్సర్ లేదు దీనికి. रुकना यार, रुकना, मैं करता हूँ कैसे। नमस्ते।